All right, we're going to reward the on-time arrivals. We've got a jam-packed agenda, although we also have plenty of time for discussion, questions, engagement with all of you. Let me set the stage. So I'm Kevin Haynes. I'm an associate director of epidemiology at Janssen Pharmaceuticals J&J. I've been running this course for many years, over 10. The focus of this course is very much a intermediate pharmacoepi course that really helps take a framework of the available database resources, what to think about in selecting databases, how to think about selecting databases in the application of the basics of pharmacoepidemiology. And so the first two talks that we'll have, Rosa Ginny will give a nice overview of sort of the state of some of the guidelines overview, some of the state of the art in a couple of the different geographies, and sort of bring us into a firm grounding. Matt Reynolds will talk about available resources. It is impossible. You will not leave here with a book of every database. So level setting, we're not going to go through every database. Although Miriam Sturkbaum's book is great, there's also Bridge to Data. There's tons of resources that that will help you with thinking about databases. But you will leave here being able to go, that database, does that fit into something that fits into one of the things that came out of today's talk, EHR, claims, hybrid, et cetera. And then I'm filling in for Dan Beechler from Carillon on validation. So validation is one of our methods components. So like at the advanced course, it's a little bit more into that weeds of the methods piece around validation. I've heard his talk many times. I will do my best. But actually, there's a link in his slides to him giving a similar talk. So if you really miss Dan, I will be encouraging everybody to watch that. And then Sudha will talk to us about some of the more advanced topics of data linkage and distributed research and some of those other pieces that sort of help tie together. So while you may hear the word linkage from the first three talks, hold a bunch of your linkage questions and discussions until the end, and then sort of vice versa. But we also have a fun activity. I say fun because I invented this activity. Please feel free in the comments to go, that wasn't fun.
Well, don't.
Oh yeah, no, don't. Right. Don't say that. Just say that to my face. Yeah, please.
If you're not Kevin, then it's
Right. And this is back from the past. We did not do this last year because of COVID, because it actually forces mingling. But I hand out databases and aims, and during the coffee break, you're to try to find a friend. That meaning you guys will have aims and you guys will have databases, and you'll have to mingle. Which I didn't want to become a super spreader event. So anyway, that's a fun activity that we'll do at the coffee break, but it also helps engage us as students of the databases. So with that, Rosa will start, and we'll end with, if we have time, we will end with going through the program and highlighting all of the sort of database activities, database SIG activities, database poster walks, and those types of things.
Oh, that's.
So we'll do that at the end. So stick around.
Yeah, I think this is because the course is part of the activities of the database. Yes, that's yes. Okay. You will find me a bit less not fantastically brilliant because I went to bed at 3 last night. So it's so just forgive me. But let's go through a kind of framework about what data sources are and what how to use them. I work in Italy in Ars Toscana, and I'm the vice president of App4U. You may have heard about that. Of course, I am involved in some of the activities that I will use as examples. So that's my, let's say, disclosure. And until last year, this talk was given by Jillian Hall, who is amazing, and I just used her slides as a basis, but she's not responsible at all for what I will say. Okay, data sources. I will not call them real world data because I don't want to use, I don't like that word, but it's the same thing, okay? So it's the reason why it's called real world data, which is reasonable, is that they exist independently of research. They are there for completely different reason, and then we use them. We exploit them as a secondary aim. And while primary data collection means that you collect the data to address your research question. Okay, that's the basic. And the fundamental purpose of this talk is just to give you an idea of the limitations, of the colossal limitations that are implied by this fact that this data doesn't exist for us. It exists for other purposes. However, knowing those purposes is something that we can include in our evidence, in the interpretation of our evidence, because we know the limitation of the data that we are using to generate it. And these are two, well, the one down, so the two guidances from our biggest regulatory agency. So this is FDA, that claims, and then we will see a more recent document that builds on top of that. We should demonstrate a complete understanding of the data sources that are used, and its appropriateness to address research questions. So two things: the data source and the research question. The data source exists without research question. And the other is EMA, that released a recent document on data quality, which is more or less the same semantic area. And this is a very big document, but I just took one sentence because there have been, even in this conference, a lot of hype about standardization, common data model, which are fantastic tools that will be described at the end of the course. However, they don't change the data, okay? So these are ways to use the data, but the data, you need to know them anyway, because if you standardize, they still are the same data with a different dress, okay? So data that are not fit for purpose in terms of answering a regulatory question won't become fit if standardized, okay? So we will, in this talk, we will speak about the bare naked data as they are generated. So we will briefly make a brief introduction, and then we will respond to the question, what is a data source? We will try to highlight the difference between a data source and the study variables. We will describe some guidance documents that are out there, and then I will tell you a debate that I have seen, and maybe you know better than me, and that will be a bit more gossipy, but I think it's nice. And then we will wrap up. So the introduction was already done. So what is a data source? Okay, let's start with the individual point of view. This POV is what my daughters say when they use Instagram. So I said, oh, yes, okay, point of view. I am Rosa Gini, and I live in Italy. And the Italian Ministry of Finances in 2003 started to create a data source with inhabitants, persons that are entitled to receive healthcare in Italy. Some years before, the Public Health Institute, the National Public Health Institute, had started recording births. They have a birth registry. So whenever a birth happens, there is a record. And I gave 2 records before 2000, before the previous thing. And then even before, the Ministry of Health had started recording hospitalizations for the purpose of reimbursement, okay? And I gave 1 record corresponding to one of the births. And then the Ministry of Finances, the same guy that records, it records medicine dispensation since 2003. And I have some mild asthma, so sometimes I take salbutamol. So this is what happens if I were to access the data, which I can do actually, and look at that. These are what was prompted for me, okay? And I really invite you always, when you see a data source, to think, okay, what does happen to a guy who is in the population of this data source? What is it that it generates, right? So let's put this at a population level. So we said the Ministry of Finances records inhabitant status since 2003. So records, when is it that the record is created? Okay, in that case, for me, I was already in Italy. So it was created the day that the data source started. But otherwise, birth, entrance in Italy, changes of address, registration of death, any of those events prompt a record in this data source. We call them data bank. Birth registry, what is it that is prompted? A pregnancy? No, it's not a pregnancy that prompts this. It's a birth or a stillbirth. So any end of pregnancy after 22 weeks of gestational age, okay? Which means that if you try to use this to make a pregnancy study, you will miss a lot. And then hospitalization, what does prompt an hospitalization? It's upon discharge. So if you have a long, very long hospitalization, you will not know it until it's ended. And upon discharge, there is this record that is prompted, and it describes stuff that is useful to decide how much the hospital will get from the healthcare system for that hospital. And then the dispensations and records are prompted by pharmacies, okay, that request reimburses for the medicines that can be reimbursed. Okay, so we have here the prompt and the guys that prompt, I mean, the organizations that prompt the records upon what I do. And on the left, there is the organization that fund or mandate the fact that these records are prompted. Kevin, please, comment. We have time. That's the.
Oh, no, I don't have.
Okay, sorry. I thought.
No. So everybody should be thinking about themselves and how they may interpret into their own data, right? So this is one example, Italy, right? My example would be, you know, the health insurance card in my wallet, right? That generates. So it may not be
Exactly.
So Dan or Matt's going to go through.
We miss
other
him so
sources
much.
That's going to expand on this, but everybody should be thinking about how their own data gets generated, EHR claims, and then ultimately then as researchers, how we use it.
Yes, and no matter what, we call them in a recent paper that we have, in a recent paper, we call them data banks. And the constituents are that somebody has the money or the power to say, okay, this data should be collected. And they say the population for which it must be collected, what is it that generates a record, and what the content is, okay?
But don't go to Spain and have a hospitalization because Italy won't know it.
Exactly. Well, it will, if at the end of the day, Spain requests, exactly. So these are exactly the limitation and strengths of a data bank, right? So data sources are composed by data banks, and different data sources may be composed by different data banks or maybe similar elements, because some of the elements that we describe here are actually also in Kevin's card. The hospitalization data bank is really very similar, and the medicines as well. It's not dramatically different, but you will not find a birth registry. And we will see something about the entrance and exit, which is the most important data bank of all. So, so what is a data bank? A collection of structured healthcare data sustained by an organization, which mandates that the record is prompted whenever a specific class of events occur to persons belonging to a specific population. That's a data bank. And we have an originator, which is the organization that puts the money or the credibility to collect this stuff. The prompt, so what is it that creates the record in the first place? Very important. Like not a pregnancy, but a birth, right? So it's two different objects. And what is the underlying population of a data bank? It's the population that will prompt a record if the prompt happens. Okay, so if I have if there is an hospitalization in Spain, that will not enter my data source because it's based in Italy. And so a data source is a collection of data banks having the same underlying population or overlapping population. Sometimes this may be a complication technically. They're not exactly the same, but they overlap. That can be linked to one another at an individual level, and then we will see how this happened. But So decomposing each data source in terms of data banks is very useful because some of the strength and limitation, they go across different data sources. So the strength and limitation of my hospitalization data bank is very similar to the strength and limitation of the data bank of Kevin. So it's important. So, and we have a kind of draft ontology of data banks created in this paper that is the hospital administrative record, the primary care medical records, and we will see in a moment that's a very important data bank in some countries, the pharmacy dispensing record, inhabitant registry, registration with a healthcare system, which is something slightly different. It will more have to see have to do with insurances, exemptions from copayment. This is a strange registry a data bank that exists in some data sources. A death registry, a birth registry, induced terminations, and then there are others, okay, or congenital anomalies. But what's nice is that you need to think that the data exists because somebody is putting it there for their own purposes, and knowing this helps a lot. And we will go through some methodological questions that you can ask yourself when you see a data bank, and of course, when you see a data source, you ask yourself the questions for all of the data banks, okay? First, culture and healthcare system. And here I will go through some simple concepts that maybe you all know, but for me, it has been very useful when I finally grabbed them. So the concept of universal versus non-universal healthcare system, I can give you the slides after, there is no problem. And single payer versus multiple payers. They're not the same concept. So a universal healthcare system is just a system where people basically cannot be without a healthcare support. It's against the law. So somehow the country manages to provide all their inhabitants with the healthcare they need, or the basic healthcare they need, right? Or the country strives to make this happen. However, this will happen in two fundamentally different ways. In some countries, like United Kingdom or here in the Canadian provinces, there will be a single payer. So the Canadian province is paying for your insurance. You don't need to choose. It's paying for your healthcare. You don't need to choose between organization 1 and organization 2. It's done by others, and it's just paid by your taxes, okay? Or the same, and the United Kingdom is the place where this idea of healthcare system, which is also called beverage, if you ever heard this word, it is where it was created, okay? And then there are other countries where there is still a universal healthcare system. It's not like you cannot not have healthcare, but it goes through multiple players. So there are insurances that can be publicly owned or privately owned, but if you cannot afford to pay one, the government will pay it for you somehow. So there is a kind of controlled market, and these are like Germany and the Netherlands. And the Netherlands is interesting because it used to be the other way, and then at some point it switched because in the 90s it looks like it was more efficient, and it was not true, but anyway, they tried. And it's called also Bismarck as a system because it was born in Germany, but organized by Mr. Bismarck, okay? And then there are countries, not many, that even though they can afford to provide healthcare to all of their inhabitants, don't. An important example is the United States, which happen to have a multiple payer system. So they have multiple insurances, some of which are public. So you are entitled to do that. But so this is the structure. There is not a non-universal country that has a single payer system because the two things somehow contradict. But it's important to have the idea multiple single payer as a concept. Is there any question on this? Was this already clear to everybody? Okay, that's interesting to know because so private insurance, they are part of multiple payer systems where you some of the big payer, well, some form of private insurance may exist also in single payer system as a kind of collateral thing. But in the multiple payer system, they are a constituent part of the healthcare system. So there are organizations that get the money from the citizen and organize and pay healthcare for them. That's the multiple payer. There are no private insurance that provide fundamental healthcare. They may provide some additional benefit, like having a more comfortable room in your hospitalization. But if you get an import, so there is a list of services written in the law, and if you need those services, the single payer somehow has to find the money to provide you with that. And then providers may be private. We are not talking about the provider. So the hospital may be private, but in the single payer system, there is a single organization, which is normally a governmental organization. Sometimes it's still called an insurance, but that's confusing. It's still a single organization that gets the money from taxes and pays the provider to give healthcare to you.
The takeaway from this slide is know your health system. Know the genesis of healthcare delivery and provision in the geographic area where the database lives. So when you're talking to data vendors or people who have data, you want to fundamentally understand. I wouldn't work with a database from Canada without working with somebody in Canada or somebody who knows the Canadian system, right? We're going to dig deeper into, I wouldn't work with a database. I'm not saying I was working with somebody who knew the data and the provenance, but this is one key step into that provenance of care. Because as you're thinking about EHR systems in a single payer where maybe, look, I just get money for taking care of this person. I may have different ways of thinking of recording data versus the US healthcare system where I gotta record it, I gotta document it so I can get audited and get paid and that type of stuff. So all of this is to think about, you gotta think about the underlying provision of healthcare in a geographic area, because it influences the provenance and genesis and the reason that data was collected.
Yes, and eventually also completeness and quality, right? So that's and then you find in your results you find strange things and you go back to this. And again, this is another very important thing that is also not written everywhere in our textbooks, I think. So I thought to describe it. So what is primary care and what are primary care physicians and what is a gatekeeper? So primary care is the care that is delivered outside of the hospital in a kind of non-disease specific manner. So a primary care physician is someone you will refer to when you have your first symptoms or you don't know and you just go there and they start and help you navigating the healthcare system. So there is a whole world of also political meaning behind the word primary care. For our purposes, what is important to know is that in some countries, and this will be irrespective of whether it is single or multiple payers, primary care physicians have a fundamental role. So every single person, he is associated with one specific primary care physician, which is often a general practitioner, GP, but may also be a pediatrician if it's a child. Okay, so let's call them primary care physician. You will hear the word GP a lot. So person, GP, there is a unique correspondence. And whenever the person needs to access the healthcare system at a higher level, unless it's an emergency, of course, that's another story. But if you need to access a specialist visit or a programmed hospitalization, you will go through your primary care physician. This happens in those countries where the healthcare system could also be different roles in different insurances. It says that primary care has a gatekeeper role. What happens? What is the consequence from the point of view of data? That if you access a primary care medical record, so the clinical record of a primary care physician, that physician will have a population, which is the persons that are uniquely associated to him or her. And about that population, the primary care physician will know a lot. Because if they have prescriptions, if they have hospitalization, if they have a lot of things, not everything, not everything, but a lot goes through the primary care physician. And the most important data bank that you will hear about that is CPRD. You will hear a lot about CPRD. This is a data bank of this nature. It doesn't have everything because, of course, the primary care physician will know that you go to hospital for a programmed thing, not necessarily that you went there for an emergency. There will be a referral in some countries, so they will know because the healthcare system will write to them that you have been to hospital, but not necessarily that will be written into the primary care medical record. But otherwise, there is a lot of information in this type of data bank in those countries where there is a gatekeeper role, okay? In those countries, very, very important data bank. For instance, Spain or Italy as well. Is that clear? Is there any question about that? CPRD, just very important one. Purpose of primary data collection. Of course, this is very important. So what is the, and in this realm, we mean what are the originators? Which organizations mandate or support the specific data collection of this data bank? And it could be the healthcare system payer, which can be the government or an insurance. A governmental body, for instance, a regulatory agency may mandate to collect some data and pay for that. A network of clinicians. So in that case, it could be more voluntary, like grassroots, and it's a different thing, right? And the purpose can be clinical, administrative, research. Sometimes it's research, luckily. But it will still be not about your research. It will be research for other research questions. Public health. In the countries where there is a single payer, public health is often very close to the healthcare system, which doesn't happen where there are multiple payers, because public health is always on the government, while healthcare system not necessarily. When you have single payers, they are together, and often you can link data banks from public health with data banks from the healthcare system. Or statistics. Sometimes there are some data banks that are created to count. And then a different thing is which is the organization that executes the data collection, which is another thing, right? The hospitals, the pharmacies, okay? This is important to know and have clear. But once you have this framework, it helps you to become familiar with a new data source. Even because, Kevin, you are talking about generating evidence. I use this also when I consume evidence. So when I read a paper, what I would like to understand is, and to see reported is this. And it takes, for instance, really a lot of time to understand the US claims database are not very well described always or referenced to. All of these things you need to understand after a while. And if you're not internal, it's like, anyway. And this is a figure that we will see growing. So we have these organizations that create the data banks. Okay, underlying population. Question for you. What is the underlying population of a death registry? Anybody suggest? The living. Exactly. So the underlying population of a data bank is not the people who are recorded in the data bank. It's the people who have the potential to be recorded when the prompt happens. Please.
But that's very specific to the geography at the time. Which died, they live one place that died, a different place not registered. Okay.
That's exactly what you need to understand when you study the underlying population of a data bank. So what's the strength and limitation of the way we describe the data bank? And what you say is really linked to time. So one thing is if the death registry is created for the purpose of statistics or public health, your death, my death, will be communicated to my death registry no matter where I die. At some point, it will be recorded because that's the purpose of that specific data collection. It's not for the purpose of delivering care, whatever. It's something. My death will have all sort of let's say organizational consequences that will eventually be captured by the death registry as long as I live in Tuscany. So between the specific date that is recorded, do you remember that I told you that there is a data bank mandated by the Ministry of Finance that says, and since 2003, it records when people enters, when people is entitled to healthcare, and when people stops to be entitled. In that range of time, you can be reasonably sure that if I die at some point, that will be recorded. Could be recorded with some delay, but it will be recorded because I'm firmly belong the underlying population of that specific data bank. While if I am hospitalized in Italy outside of Tuscany, this will also happen because somebody will ask Tuscany the money. If I am hospitalized in Spain, this may not happen. Okay, so the strength and limitation of the underlying population. And what is really, really, really important is the list of persons that are in the underlying population of the data bank, including the dates when they start and then when they end to be in that underlying population. Is it recorded in that data bank or in another data bank that can be linked? That's a very important question for the data source, right? So when we put together the data banks, this is, as you can imagine, since we are all epidemiologists before being pharmacoepidemiologists, this is the most important question of all, because it's what constitutes your population. And so for instance, the primary care medical records that we were mentioning, it's a data bank that has its own cohort inside the data bank itself, because the primary care physician will know who their patients are, even though the quality of those dates may be a bit blurry. Because when a person goes away, a healthy person, the GP may not notice, or maybe they receive the communication, but it's not necessarily that they write this down. Okay, so there are conceptual underlying population, there are dates, and then there is the quality of those dates that you should question at some point. And we will see this more when we speak about data sources. Okay. Is there any question on that? So remember, what is the underlying population of a death registry? It's not the underlying population of a data bank is not the people that are in the data bank. So I am in the data bank of hospitalization, even if I have never been hospitalized. So if you have only that data bank and not the population, you are missing a piece. And then prompts and units of observation. So unit of observation is the fundamental concept of science, right? So you need to know when you do science, you need to observe stuff about units of observation. And we have those data banks. What are the unit of observation of a hospitalization data bank? It's the hospitalization. It's not the person. So in your study, you want to collect variables about your persons, your study subjects. And in order to do that, you use information that has been collected about other units of information, which, and it's important, it's useful, but they are two different things. For instance, this is a hospitalization record. The identifier of the hospitalization is really the unit of observation. And then the identifier of the person is an observation about that. It's just a variable. Okay, so who was the person then? Who was the person again? Yeah, it was you. Okay, it's important. But then the diagnosis, they are not telling you what are the diseases that that person has. No, they are telling you which were the diseases that were relevant during that hospitalization to create the DRG, to create the value of that hospitalization, okay? So if you see all the diagnostic codes of a person in their history, it's not the set of diseases that they had if it was only from hospital, because it's the diseases that prompted hospitalization records, okay? Data content, data model, and data dictionary. Okay, that is surprisingly rarely displayed. So up to today, and I've been doing pharmacoepi for almost 20 years, I've never seen precisely the data model of the US claims, even though, I mean, I guess it's not, they must be similar to other data banks that I've seen, but it should be very easy to display. So this data bank is composed by 3 tables, and the tables have these names, and each table has this variable with those names and the values, and the categorical variable have this, okay? This is something, it would be useful to know them when you read, because that's at the end of the day what is collected, and whatever you build on top of that and then transform into the common data model, and then you do your variable. But at the end of the day, this is what was collected. So I think it would be, that's a recommendation. So I'm doing this diverse scoping review within the database SIG. I think this will be a recommendation that will come from us, because, okay, why not? It's such a simple information that would help so much. It doesn't tell you anything about the prompt. It doesn't tell you anything about the underlying population, because those notions are outside of the data. But still, it describes the content. So why don't we have that more often? They tell us a lot about the international coding system. It's ICD-9, it's ICD-10. Okay, thank you. That's important. But what are the categorical variables that you are collecting again? What's the values? Time. Okay. How often data is refreshed? When the data collection started? Lag time between one, so when it was last collected, when we obtain access to it, and then the median or mean duration in the data bank of every person. These are informations that are related to time, and they are often displayed, or anyway, they should. That's something you find. It's a recommendation from the old guidance of ISPI. Completeness and quality. Wow. Okay, normally the originator that pays for the data bank checks that for the primary purpose, the quality is good. So that's something we can, if we don't have specific information, it's something that we can somehow trust a bit. Often the data bank is created for purpose of payment. So, or if it is voluntary, it's normally something that is close to the purpose of the people who collect the data. So, or there are laws sometimes, you know, really you think for the primary purpose, the data will be okay. This is what is called reliability of data. And then if you look at the documents of FDA or EMA that I showed you earlier, they will be referred to as reliability. But whether this translates into quality for your purposes or for the purpose of the guys who did the study that you are trying to interpret, well, this depends on the research question, right? Because that's a different set of data at the end of the day that is created to address your research question. And this is the concept of relevance. So whether the data source is, or the data bank that composed your data source are relevant for the research question, okay? Okay, so these were the list, 1, 2, 3, it's 7 dimensions of that I recommend to use to understand all the data banks of the data source that you want to understand. Is there any question about that? Does it make sense? great. Or it doesn't at all. And now data sources. Now we had, you remember that piece of figure on top. So there were those institutions that for their own purposes, they were creating data. And then there are other institutions that often work in networks with investigators, or they may be investigators themselves, that happen to have access to more than one data bank, or even one data bank can be a data source anyway, for the purpose of research. They are the secondary users, okay? It's us, or some of us, or some of us may be the investigators that work with these guys. So there must be some legal monetary thing in place for those people to access more than one data bank, or one data bank can be sufficient, or the same originator may create multiple data banks that are naturally linked with each other. And that's something that will be described later. But no matter what happens, there are the data banks, and then somebody can link them together. They will still be different from each other. They will still have possibly different underlying population, or slightly different prompts, different content. At the end of the day, they are together, okay? And you have somehow a relation with an organization that can link those together. Question on data sources. Underlying population. As I said, this is the most important of all. Does the data source include at least one data bank with dates of entrance and exit from each data bank? If so, what is the validity of such dates? Otherwise, how would you interpret lack of information? And we will see now in a second a very important example. Is the underlying population of all the data banks the same, and across the same time period? Sometimes one data bank is collected, I showed you at the beginning, is collected in a different time period. And in that case, there will be, or maybe it expands to a different population, okay? So an example where you have a very well-defined cohort. This is the Danish data source, the data source that is, in essence, the healthcare data plus some data generated for statistics or for public health or for other purposes. So it's a very rich data source. And then universities and other research centers can have access to some data banks for some specific purposes. But in itself, there is one data bank that has the date of entrance and exit from all the others. And this, as you say, in epidemiological terms, the population of Denmark, not only the Danish citizens, it can also be residents for legal residents, is an open cohort. And you know the date of entrance and the date of exit. Fantastic, okay? And within that, you make your study. All the data sources nested in a single payer universal system, they will be linked to residency, to inhabitant, to being there. But limitation exists on the date of exit, because if people go away, they may not communicate this to the country because they just go away and they just live in another place for a period. You would need to understand this, especially for young people. You may find that there are a lot of person time with no prompts, which is okay. You normally interpret this as healthy person time. Nothing happens means, but the person is in the population is an information, right? Okay, you need to be careful because sometimes this, you need to understand the limitation of that really well. In multiple payer system, it is normally better because if you are have not exited, you still are requested to pay. So the quality of this date in multiple payer system is naturally better. And then there may be exceptions, but that's a rule of thumb. In primary care medical records with a gatekeeper role, as we said already, this is recorded in the data bank, but they might have limitations. Young people go away, you have never seen them as a GP because you never saw them anyway because they were healthy, and then they're not just there and you don't know. The opposite case, the hospital electronic medical records, which are very good quality data banks in terms of content. They have a lot of variables, a lot of great. But there is no date of entry and date of exit in itself. There is not a very well specified underlying population. Gosh, guys. So it is difficult to interpret when you have absence of record. Is the patient healed? They don't need care anymore? Has the patient died, or are they cured by someone else? How to interpret lack of data between two visits? Was the patient healthy, or the patient took care somewhere else? And there is a partial workaround to this, which is anchoring. So since you know that, so you only restrict your analysis to the days around when a person was actually seen, because you can somehow assume that if a person was visited one day, probably around that day, the information was complete. It is an assumption. And this is a study where this is done, and for some reason they do it also for the other data sources, but which is wrong, because if when you do this, you are of course reducing the amount of healthy person time in your analysis. So it's something that you should only do if necessary. If you do have dates of entry and dates of exit, don't do this. Okay. Is that clear at all? And then Kevin was speaking about the expertise. That's a recommendation of the guideline for database selection. Yes, it's very useful if you are the investigator and you're using a data source, if you have the attention of including in your study team persons who are really closer to the data source than yourself, if you're not really familiar. And then another question is the update time, if it is the same across all the data banks. Now that during COVID, we had to produce evidence very quickly, and then we had data sources where some data banks were more recently updated and some data banks were just older, and we had to cope with that, okay? And then the most important thing, and this is the second part of this talk, is based on prompts, content, time from all the data banks, what is the expected validity? What is validity of the study variables that can be observed on the underlying population? What is validity? So I have my study population and I create the variable, the people on baseline had diabetes or not. The validity is whether that variable is correct or not. And it's not a variable that was collected at the beginning by the data bank. It's a variable that I create, and we will discuss this in a second. Another concept is the instance of a data source. So when you are doing a study, you receive a specific, it's also called data cuts sometimes, right? So the data source exists, the data banks exist independently on you, and then you have permission or the money to access an instance. And it is a selection of the data source. You could have all the data banks, or maybe just some, because they are pertinent for your research question. The underlying population, you could have the data about all the underlying population or only a selection. You could have the time since the inception of the data banks or only for a period of time. The end dates, the same, up to the most recent record, or of all the data banks, different from each data bank, or a cut on the same date. The content, you could have all the tables and all the columns, or a selection. All possible values, or a selection, only some codes you may have. And time, is the date of update the same across all the data banks? This is the instance of the data source or data cut. And then you do the studies. You have all, these people were generating the data, didn't know anything about you. The data banks are there. Some institution can link the data banks and have the data sources. And then there is a research question, possibly another institution wants to address that research question. They create the study, they create a kind of study team with the data custodians, and then the study is executed and it can go through the common data model, for instance. That's something that may happen, and we will see that, but that's something you do on top of data that exists already. And then you create the study variables. What are the study variables? measuring, phenotyping, operationalizing algorithms. It's all the same thing. When a research question is asked, you have your population and you would like on every person to observe blah, blah, and blah, blah, and blah, blah, and blah, blah. Okay, that's in your protocol. Can you do that? No, you don't see those people. No, you have your instances of the data banks, and you have each data bank is in some period, right? And you have the prompts. So your job is to observe your study variables on your study population based on what you have, right? On the prompts, on what has been observed on the prompts by somebody else for their purposes, and blah, blah, blah. This is your job. And across the literature, this is called, okay, you use sometimes the look back period, for instance, at the baseline. In order to observe something at the baseline, you use all the time, that all the prompts that have been observed in a period in the past. This is very common. And the very important question that you ask is, if you want to observe something at some point and nothing happens, can I say that my variable is 0? And as we saw earlier, it depends a lot on the underlying population. So if the person is in the underlying population and the event of interest would prompt a record. That's the two basic principles. And then measuring. This is a term that is, I think, correct. That these are two papers that use this term. This is I think, methodologically, that is the correct term. So you are measuring variables based on something that you have. Another word that is used a lot is phenotyping. And this is used more than by people that have more of an informatics background. But it's the same thing at the end of the day. Or operationalizing algorithms, this is the term that I use, but I think measure would be more correct. Because this is what you do in practice, right? You create rules or prediction models based on your prompts, and you generate your variables. These are some papers that use this word. What doesn't matter. It's just weird that we don't have a term for this very important activity. What matters is such notions are approximately equivalent. Study variables are unit of observation that are different from the unit of observation of the data banks of the data source. Yeah, generating a study variables is a choice of the investigators and have consequences that you need to understand. And this is a case when you see in different data banks, in different data sources, the same event has a different incidence. This is coronary artery disease. In data sources with GP data only, the incidence will be lower, not because there are less coronary events, but because they will be captured less often. And in inpatient, it will be higher. In inpatient and emergency room access, it will be higher again. And the opposite happens for anosmia. This is more often recorded in GP data sources, because if you have anosmia, you don't go to hospital, right? It's okay. So when you measure your study variable, you make use of your data source, and this will create a variable that has a different validity according to the different characteristic of the data source. So study variables have imperfect validity. Their limitations must be taken into account when interpreting results. To understand validity, knowledge of the characteristic of the data banks is very useful, even when you cannot validate, although if possible, and we will see Dan's presentation given by Kevin, please validate. I will just go very quickly through some documents, existing guidance for selection of data sources. The oldie but goodie is the guidance for good database selection and use in pharmacoepidemiology research. I will just, so basically the checklist for investigators in database research, the point 1 database selection is more or less what we have said already. So even though this was published more than 10 years ago, more or less, this is still true. Population cover, capture study variable, continuous and consistent data capture, record duration and data latency, database expertise. It's what we said already. And then the specification of the extraction, this is the instance. A more recent is the document by Nicole Gatto, a structured process to identify fit for purpose data. And they have a set of tables that you should fill in. I think it's a valid. I think it's still a bit US centered, but still it's good. I really recommend to read this because it gives you. And then upcoming Minerva, you've seen the figure that was building up, that was from the Minerva project, and Diverse, which is from the ISP database. They are upcoming. And then this is just an example of fit for purpose assessment. So here the data sources were described pretty well. I mean, the important things were there, and then some variables were observed on all the data sources so that you could have an idea of the validity beforehand. And then finally, the spicy thing I had promised. So almost 2 years ago, the FDA wrote a draft guidance where they said, you know, because there is this issue of validity, if you want to do real world evidence, another hype word, and as to make regulatory decision based on your real world evidence, you need to come with validation of all the variables. Okay, which would be fantastic. Indeed, it's important that it is acknowledged. It's important because sometimes people don't realize that study variables are different from the origin data, the difference between reliability and relevance. So it's important that they have said so. It's just, okay, so in April 22, there was a response by our president, Vincent Loret, and other very valuable colleagues, and they said, okay, it's even more that it is requested to randomize clinical trials. How are we going to do that? And validation, the problem is really with validation, the problem is really false negatives. So how is it that you assess sensitivity, even though there are ways? So I do not completely agree with this response, because I think that there are, and Dan, and I think you will probably say.
Pause this debate. We'll have the
yes. Yes, exactly. And the nice thing is that the guidance recommends practices that would significantly limit the ability to use real world data. So it's a kind of, it's an argument that is not very strong. And I think that we should have the humility of acknowledging that this is how we generate evidence. It's not that we generate fantastic evidence. We generate the evidence that is like, it's a bit like democracy, that it has terrible consequences, but nothing better is available apparently, or well, according to most. So that's the same for real world data. So wrapping up, data sources are composed by data banks. We have listed a set of methodological questions you can ask yourself on each data bank so that you understand what's going on. And then the questions on data sources when you put together the data bank. And when a research question is asked, you want to have the study variables, but you don't have them. You use what you have to create that, to observe them with imperfect validity. Then we have some guidance documents, especially the oldie but goodie. And then there is this nice debate, and we will know more about that. Thank you very much.
Any additional clarifying questions? I mean, we're going to have plenty of time to discuss, so we don't need to dive into too much of the weeds, but there are clarifying questions.
I guess when you're using the term instance, you mean observation, right?
The instance of the data source, you mean? I didn't understand. When you use the term instance, okay. It's really when you are executing the study, you receive a set of tables, a set of records. This is not the data source. The data source is something that is updated regularly. This is the specific set of data that you receive, that is generated, is cut from that data source.
Right, so I would think of it as an observation period.
It could be the observation period. They could also restrict the population. They could restrict the columns that they give you. They could restrict the values that they give you. Because sometimes in order to access this data, you need either to pay, which is functional to those things, or you need to satisfy some legal requirements. And then the instance that you receive is not the whole data source, not necessarily. And all of those things that I listed are the limitation of the instance that you may happen to take into consideration.
the other key thing to think about that too, is that even if you made the exact same request for the data, but you did it 6 months later, that data set is going to look very different.
Exactly.
Sometimes, surprisingly enough, sometimes in the data, like you think, okay, well, I get something 6 months later, there's going to be new data added to it. Sometimes stuff disappears because they've made changes or they've gone back and corrected things. So, I've seen patients disappear, I've seen events disappear.
Well, CPRD all the time.
Problem when you analyze data repetitively. But I mean, that's to me one of the biggest. There's a lot of patients, the drugs, and people and events. So having that document for when you got it, so that it could be replicated, you went back in time, is at least some helpful for your documentation.
Oh, yes, interpretation.
Sometimes data sets change the way that they code variables. Well, you can do that. So from one time to another, they end up with totally different definitions.
So as we transition here, I will offer up my favorite research question whenever I meet with a data vendor for the first time. So Matt has changed to a new data source. So I always, whenever I sit down with somebody who goes, I have got a database, and so feel free to walk the exhibit hall with this question. I want to study pediatric antibiotic exposure in the first 2 years of life and its effect on the developing microbiome on the outcome of colorectal cancer. Okay, while we were sitting here, I just got texted to confirm my colonoscopy appointment, right? Because I'm eligible to be screened. Where are my pediatric antibiotic exposure data? What data bank is my pediatric antibiotic exposure? It's in a closed pediatrician's office in Bud Lake, New Jersey. Okay, that doesn't exist, right? So this research question will be able to be answered years from now. My grandchildren will be able to link their child's data from PedsNet, which is their Children's Hospital of Philadelphia, contributes this data, or Trinetics, or some of these other EMR-based systems or claims-based systems from the US. They'll have to link my kids' data to their Medicare data, 80 data bank, right? 80 years from now, right? So my grandchild's PhD dissertation, they don't know it. They're not born yet, right?
Denmark.
Well, or you go to Denmark, right. But these are the types of things to be thinking about, right? So all the questions that Rosa just raised is as you're asking data vendors and people who proprietary data, those are the types of questions to ask. And now Matt's going to sort of help us think about the selection of databases. Given an aim, how do you start to think about all the things that we need to think about that feed up a database before we start using it?
Yeah. I appreciate everybody coming out. First one out to shoot, 8:30 in the morning. You guys look mostly awake, although I could use another cup of coffee. So I know I'm probably up against the next break. So I'll try to. I think I only have 214 slides, so I should be able to go through this. It's not really that long. Okay, so I'm actually, the talk that I'm going to give today. Let's see if I've got an agenda here. All right, I'm currently at a company called Flatiron Health. We have an oncology EHR in the U.S. I have one slide where I'll use it as an example later on. Before that, most recently, I just went back the last 12 months, was employed by IQVIA, who in the US, actually globally, huge data vendor, also CRO as well. So some of my experiences from there. Before that, United Biosource Corporation and Evidera for 16 and a half years of doing various data. So I learned a lot about databases. I started my career programming in MarketScan, one of the 2 claims data sets that were available. Back then it was big when it had, I think, maybe 3 million patients in it. IQVIA's Pharmacoepidemiology Plus is well over 100 million patients in a closed claims data set now. And the one EHR that I ever got to touch my first couple years in as an epidemiologist was actually GPRD, which was the CPRD now. That's how old we are. I did want to point out too, the oldie but goodie that you noted up here, Rosa. That paper, the guidelines for database selection for good pharmacoepidemiology, actually came out of the database special interest group here. And so that was the first paper that we published. And it got me thinking, because I actually created that SIG, and I did it because I was living in databases and I wanted to talk to other people about all the problems and solutions that we're having. And there's a lot of smart people at this conference. And I did it in Quebec City. So kind of back to Canada here. So just it got me thinking back to old times. I will ask for you to ask me questions as we're going through this. I'd like this to be a little bit of a back and forth if possible. Ask for clarifications now as opposed to at the end, because either you'll forget it or we'll have fallen asleep. And I would like to, address it to make sure that we're all, talking the same language as we move forward. So some of what I talk about will overlap a little bit with Rosa. It actually will overlap probably with Soda and some with Kevin as well. And but I think where we go into depth will be differentiated. So I always start here. What are our available data sources? And I'm actually now glad I didn't say real world data sources, based on Rosa's preference. I'm going to dig in mostly in this talk to the claims data sets and the EHRs, because they are the most predominant ones where we are able to grab them off the shelf. And they're probably the ones that you're most likely going to touch and use for first pass, large, population options to do real world data studies. I am going to dig into open claims. I added 4 or 5 slides here to the deck because 2 years ago, we talked about this for a while in an advanced pharmacoepi class. So you guys get a little bit of advanced here as well. I'm going to be really kind of beginner, and we'll go into that a little bit because they're tricky and they are available, and they look so good because they're so big, but they have some limitations. And Rosa alluded to a few of them as well. Then also the other things to keep in mind here, we have lots of other options to collect data. We can survey, we can do chart extractions, we can do registries. And these days, it was funny, think back to 24 years ago when I started, we had claims and EHR, right? And then we're like, well, we need stuff that's bigger. And now we need claims that have EHR or have chart ability to get in and get some of the text. And now we want to link these. And now we want to link them to this and another and genomics and here. And as pharmacoepidemiologists, we always want more, right? We always want that next step. There are problems with doing that. I think we'll hear about that in a future talk here as well. But there are ways to potentially solve our problems, especially when we think through the pros and cons of the different data sets and the process of doing this, that actually can create some pretty cool combinations of data that still hold value and are reliable for us. Administrative claims. So what are administrative claims? Claims are these are very US centric. There are some European countries that have setups like this as well, but they're really billing interactions. They're coming through insurance companies that provide reimbursement or pay for the services that the patients or enrollees are undergoing. So each one of these pieces of information are billable interactions. It could represent prescriptions, outpatient visits, ER visits, hospital visits, etc. They have basically everything that has occurred medically from the time that these patients were covered should be in this data set. It's not exactly true. I'll point out at least one instance where it's not, but it's a pretty good assumption for the most part, because most of us, we don't like to pay for things that we don't have to, right? So if we've got insurance and somebody's going to pay for our medical care instead of us pulling cash out of our pocket, I think most of us would agree that's usually our preference, and hence that's why most of that care should show up here. So I'm going to walk through the 4 different categories here: outpatient, inpatient, pharmacy, demographics, and enrollment. I probably should have pulled that out because it's 2 different things. And that enrollment data is really key. And it's going to be the big differentiator when we talk about closed versus open claims and our epidemiological use or appropriate use of this type of data.
The linkage for both, that's that population, those 2 together. These are 4 data banks all within one data source.
All in one data source. Yeah.
We might buy or go and work with the data source. It is 4 data banks to your life, but to us, it's a one data source.
And I 10 years ago when I was doing these talks, and these things have evolved over time, I actually would name some of the individual data vendors. So for example, a closed claims data set right now, Pharmetrics Plus from IQVIA is a very big one. MarketScan from Truven, a very big one. Optum and Carelon, used to be known as HealthCore. They look similar. They're closed claims, but they are single payers. So they have other options since they know who those patients are and can get back to charts, which some of the others can't. They all kind of look the same and sound the same, but there are differences across them. But for the most part, the core of them with the outpatient, inpatient pharmacy enrollment and the limited demographics we get into will look pretty similar. And they use the same coding schema in there, but the infrastructure may look slightly different, but you can likely ask the same questions to all of those different options. I stopped talking about individual data sets because after a couple of years and having data vendors come to me telling me that I mispresented the number of patients that were in there, or, hey, we actually can do this now. I'm not trying to sell a data set. And so I'm just avoiding those kind of issues. And I'm not trying to show preference for any data vendor or disparage anybody. Although if we want to have a drink somewhere after this, I'm happy to disparage some. So outpatient claims, these are the most frequent type because they occur more often, right? They typically provide the following, these patient elements. They're going to have your patient ID. So you're going to have your unique patient ID. It's going to be something that's, some non-identifier, but it will allow you to link that individual patient longitudinally across all of the data within this data set. The date of the claim, where it happened, place of service, who treated them. And then you'll have procedure codes and diagnosis codes. They basically give you insight into what the heck happened. Why did the doctor see this person? Did they do anything? All of that information will be built in here, and it may not be a single claim or a single line item in there. It might be 23 line items, same date, 20 different diagnosis codes and 3 procedure codes, and you'll have to find a way to code that together to be able to incorporate all that information. And then you'll have costs or charges depending on the data set that are associated with that claim. You have inpatient data. In most of the claims data sets that I just mentioned, the inpatient data is, oh yes, Rosa.
So I had a fundamental question about those two data banks that I am unable to answer.
Okay.
What about, I know that medications that are offered during hospitalization are normally not captured.
Correct.
But what about medications that need to be delivered in a hospital setting, but not during a hospitalization? Are you able to capture them? Like, I don't know, many cancer drugs or biologic drugs. Are you able to capture them in one of those two data?
So if you're not going to see the oral meds pop up in a traditional administrative claims data set in the hospital table here. But if there is an infusion code, an injection code, if the drug is provided that way, you may very well see it in here with the
procedure code.
Yeah. Depends on how specific the procedure codes are. Yeah, Kevin.
Expensive drugs are going to be billed by line items in inpatient claims. I gave an infusion of this wickedly expensive drug. Absolutely. I gave vancomycin 1 gram Q12 on 5 South. Absolutely not, because it's going to be rolled up into a giant DRG code. There aren't pharmacists running up the street to the local pharmacies to fill NDC scripts. So you're not going to have the level of detail, especially for inexpensive drugs. But inpatient infusions are absolutely billed. They're very expensive, and the insurers want to know what they're paying for.
Where can you recommend any article or book where I can find this
Miriam's book, the chapter on U.S. claims, Medicare data. I've got tons of it.
Okay.
All right. Good. So in the inpatient data in here, typically it's oftentimes it's rolled up. So you'll see the date of admission, a date of discharge, a total cost, usually a primary diagnosis, which could be, sometimes you got to be careful and ask, it could be a primary admission diagnosis, could be a primary discharge diagnosis. Those are oftentimes different. So you can get the length of stay. As Rosa just per her question, you don't get the oral meds in here. You'll get the diagnosis codes. You'll get procedure codes. So if the drug is driven through an infusion, injection, has procedure codes, they'll likely be here because they're costly, as Kevin pointed out.
A lot of cheap IV. You're not going to get You're not gonna get billed for normal saline.
Yeah.
You're not gonna see a bill for normal saline. Pennies on the dollar, it's not worth the University of Pennsylvania spending the time billing for 89 cents worth of normal saline. You're just not gonna.
But there are ways to get at that. There are ways to get at that. Now I'll get it in this last bullet here. While what I'm walking through is sort of the general way that these are set up, there you'll also find in some of these that you may find some of the inpatient claims or the detail in there to look more like the outpatient, where you could have 32 different pieces of information in here about the date of during the hospitalization with different diagnosis codes and procedure codes that might give you more information than the rolled up summary that you'd get for the hospitalization. Now, there are data sets. This I've called it hospital charge master. This is US. I express my US bias here, but it would also work for hospital data sets outside of the US as well, where you get really granular detail within a hospitalization. These data sets, and Rosa alluded to it as well, you can see the unit of observation is the hospitalization. You know what happened from the time the patient was admitted to the time that they were discharged, with absolute phenomenal detail all the way down in some of these down to how many aspirin were provided, how many, on what day. You can get I did a study on here about 3 chamber versus 4 chamber total parenteral nutrition bags. I was able to look at what nutrition they were getting while they were in there, what bags they used, and how they were compounded. Like I did a study looking at surgery and whether they used staples, sutures, and or some sort of topical hemostat. And you can get down to that level of detail within these data sets. Problem is, you don't know what the heck happened with these patients before they got to the hospitalization, because you don't have their history. You don't know what drugs they were on. You don't know what issues they had. You can pick up some of it based on what drugs they may have given them in the hospital. And in here, you do get all the oral meds as well. You can pick up some of the concomitant, comorbidities and stuff just based on what they're treating that patient for and what they've documented in there. But you don't know their history. You don't know what drugs they were on before. You don't know what they failed. You can only guess and infer. And then once they leave, you don't know what happened, unless some of these data sets allow you to link, and you might be able to see if the patient was rehospitalized, with the caveat that you don't have every hospital in here. It might only be 10 to 20% of the hospitals in the country. So if they go to a different hospital, that lack of data doesn't necessarily mean it didn't happen. It either didn't happen or you can't see it. And that's where you start to get into a sticky situation. Yeah.
Analogous for Rosa going.
Yeah. Yeah. So
We could go across the street, and across the street is Spain.
You took him by generic or the brand?
Yeah. I think it's pretty detailed. I can't recall, but I think it's down to I think it's got brand and generic information in there, if I'm not mistaken. Yeah, I think so. I could be wrong. I've run into problems before with some of while the drugs are noted by the day, the diagnoses aren't. So, for example, I tried to do an anticoagulation study and look for VTEs, or venous thromboembolisms, and I couldn't tell whether the anticoagulants were used as a prophylactic or a treatment, because they could be used as either. I just know a VTE happened. I don't know whether it was a failure or whether the drugs were being used as a treatment. So not a good fit for purpose data set for that. So pharmacy, the other very voluminous data element in here. You get all of the prescription drug coverage here. Now, not every claims data set also has prescription drugs. So when you talk to your data vendors and you say, they tell you how many patients they have, and they say, we have, I don't know, 50 million patients in our data set. Okay, well, how many of them have inpatient data and outpatient data? Usually that number will pretty much be the same, because if you're covering medical insurance, it's there. But how many do you also have prescription coverage for? Okay, well, that number's 27 million, because the prescription coverage is not always provided through the same company that's providing the medical insurance. It might be, you know, I don't know, you U.S. folks here, you might have Aetna or United Healthcare for your medical, but your prescription card, you have a separate prescription card from Express Scripts or some other provider. So it's a question of whether they're able to get all that information together. And it's usually still a pretty big number. It's a you know, I don't know, 60% or more most of the time. But it, you know, it's a question to ask when you're trying to find out what your actual population is you can work with. They have very detailed drug information. This blew me away the first time I was in there looking at Celebrex and realized that there's not a code for Celebrex. Were hundreds of codes for Celebrex, because if you get it in a blister pack, if you get it in a pack of 6 versus a pack of 30, or you get it in a different colors, size, dose, every single combination and provision and packaging of this has a different set of codes. So if you want to make sure that you've got all of the drugs covered, you got to make sure you've got a pretty comprehensive code list here. The prescription claims do not tell you what they're for. Many drugs out there have multiple indications. So just because you see the drug, you don't necessarily know, let's say with Celebrex, whether they're using it for rheumatoid arthritis, osteoarthritis, acute pain, what type of pain, don't know. Just know that they got it. But a smart epidemiologist can usually go back into the medical claims and say, well, what other diagnosis codes were here? You know, did they have osteoarthritis? You know, what else, other diagnosis code did they get the same day that they got this prescription, filled, or within the, couple days prior? So you can be a sleuth and figure it out typically. Okay, I think those are all. Yeah. No. If you got it, if they were leaving the hospital, unless if it was filled by a hospital pharmacy that then billed it to your insurance or billed it to your prescription insurance, then yes. If it was billed as part of your hospitalization, then no. So, and then when we get into EHRs, there can be some exceptions because, if you're sitting in the Veterans Administration, a big EHR data set, they've got a pharmacy sitting in there. All of that stuff is going to be much more completely captured within a system like that. So it's a good question to ask when you're evaluating your data sets. But I don't know exactly. We'd have to find out. I don't know how hospitals typically bill that. So What kind of data? Oh, so you'll get quantity dispensed and days supplied. Yeah. And then you get in things too. I remember working with like a herpetic, neuralgia, where it was, one of them was like a topical strip that the patient would cut up. Another one was gel. You have no clue how much they're using. You just know what was prescribed, and then you can look at how quickly it's refilled and then try to back calculate. But again, it's guesswork. But no, you don't have the instructions on there other than days supplied and quantity dispensed in most U.S. claims data sets.
When you say days supply, is this a separate field?
Yeah.
So for how many days you are supposed to use that?
Yeah.
So I'm a pharmacist in the US. I fill prescriptions. So I've been audited, meaning like for Fosamax back in the day, if you put in 30 days supply, you would get rejected for a 30-day supply.
Yeah.
You're a moron. 4 times 7, 28. I am not paying for this. So Brian Strom used to say, the day supply was a random number wherever the pharmacist hand hit the keyboard. And I told him, not anymore, Brian. Change the line in the textbook because it's highly audited. But to the point of cutting strips and Medro dose packs and, eye drops and all those types of things, yes, 14, 28, whatever, it's a guesstimate. But no, you're not going to get Sting because it's not part of the adjudicated claim, right? It's in CVS. CVS knows what they put in there, but it's not part of the adjudicated claim because it's not part of payment. So I wouldn't, even if I had it, I wouldn't trust it because it wasn't part of the claiming process.
it's not.
But in most of the cases, you will get something like, let's just use the round 30 day supply, right? So if it's twice a day, you might see 30-day supply, 60 pills dispensed, and you can do those calculations in there. So it's not perfect. And, in any data set, first of all, there's no perfect data set, but in any data set, you're going to find some where it's missing, only one's filled out, and you have to do your best with it. Yeah. I'm sorry, I thought you were going to say something too. So here is the vast amount of demographics we typically get in claims data: gender, age, insurance plan, and geographic region. Now, there are ways to go back to the core data and get more detailed information around zip codes and things like that, but it's pretty limited. So this is about typically what you get. There's no race, ethnicity. There's no information about smoking status, things we'd like to see as an epidemiologist. So you do with what you have. So there are ways to enhance your core claims. There are, some of them have laboratory values. Optum has a lot of lab values in for their patients. Others have smaller linkages to them. Diagnostic tests. And what you will typically find in the claims data sets is you'll find out that a diagnostic test was done and billed for, but you don't know what it said. You don't know the result. So there are ways to be able to potentially get the results of these. Linkage to mortality data. You think this would be fairly standard. It's not. And the core mortality data sets in the US have limitations. Social Security data set used to be our go-to 20 years ago. The way that it's put together now actually is probably 60+% complete for the US population. So that's a pretty big chunk of patients that won't be in there just due to regulations and what, there's less force in making everybody report all of the deaths these days. NDI, the National Death Index, that's our gold standard. It's great. It probably has, I think it's 97, 98% completeness in there. Problem is it's on a 2-year time lag. So if you want to do something with pretty recent mortality information, you're not going to be doing it if you're looking from the die in the past 2 years. You can link to medical chart or EHR data. So, in many of these claims data sets, you can actually get to the chart where you go, I need more clinical detail. I need to know the severity of the disease. I need to maybe understand why they did something or additional information around a particular event of interest. There are claims data sets that allow you to get to that. You can also link to an EHR. There are some data sets, for example, Geisinger Health System as one example. It's a health system. They have EHR for all of their health system, multiple disciplines in their GPs, specialists, hospitalizations, ERs. And then for about 40% of those patients, they're actually on Geisinger insurance as well. It's a local, insurance in that area. So there is a nice size subpopulation in there that have both claims and rich EHR text. So that's some that's kind of already pre-overlap. Most databases don't include non-billable. So you want to look at use of ibuprofen. Not likely going to be able to do that too well in these data sets. You'll find some of it in there, but you're definitely not going to get all of the Advil and such used off the over the counter. Out-of-pocket expenses, not going to be there. As was also noted before, what I've talked through here with claims, they are, the ones that I've mentioned have been primarily commercial, so working age population. Once you hit 65 here, or once you have a life, let's say a disease that prevents you from working, you likely can go on to Medicare here in the US, and it's a totally different data set. So what you'll find are patients dropping out of here. One example, I actually worked on a study where we're looking at HIV patients and looking at incidents of renal failure and renal dysfunction. And we kept seeing gosh, as soon as we see this event, then the patient's enrollment ends. What is going on? Why can't we get any follow-up? And it's because once you get renal failure and you go on to dialysis, you're going on to Medicare. So it's not that, what we were seeing was great, but then we were losing the patients because they were now being covered by a different provider. Similar kind of thing for Alzheimer's, looking at, even in the EHR, looking at the gradient of severity. And as we had plenty of mild and moderate, but the advanced ones, we'd see them and then they would disappear and we'd never see any more activity because most of them were going into nursing homes and other care and they weren't coming back to that point of service within the EHR. So again, understanding the patient flow and the type of care that's being used there, super helpful. Diagnosis codes and justifications for service definitely can, represent rule out diagnoses. Yeah. Depends. Yeah, it probably depends. Like, I am not a health policy or a guy. I can't tell you for sure, but I can tell you that, if there's if there's there's likely rules, within the states that will help you answer that question. I'm not the expert on there. I'm thinking back to like multiple sclerosis, renal failure, those kind of things. Like once you get to the point where it becomes severe enough you can't work, I know there's considerations for commercial to send you on to Medicare where you'd get better coverage for things and or pay less for them. And Medicaid may be another option as well. I don't know the triggers that would drive you to Medicaid. And Medicaid, for those of you who don't know, is another insurance that is supported state by state, different rules state by state. That covers typically those that can't afford insurance, and so it's a lower socio demographic, typically socioeconomic status. So it's providing insurance that way to. So I don't know the answer.
But
Yeah.
it's complicated because then some of these plans are administered by commercially insured, so there's Medicare Advantage. So even though people disappear from commercial insurance, they may reappear in the same plan with Medicare
Yeah.
Advantage. The Kaiser system, like the Geisinger system, when you retire from a Kaiser health plan, you're actually eligible for Kaiser's Medicare.
Yeah.
And so this is why you need an expert with the data and the health policy to sort of be at your research table, so that you don't run into all these.
Well, and even for Medicaid, what might happen in Tennessee might not be the same thing in California or Maine. Each state, the rules are not exactly the same for state by state. So, I thought I saw another one. The diagnosis codes, and I'm sorry, I'm kind of going off on tangent because there's interesting things here that I think will help you understand how to choose your data or what questions to ask. The diagnosis codes, the rule out diagnosis. Anybody know what a rule out diagnosis is? Like, you guys familiar with that? Anybody ever tried to conduct a study in a data set where this is a major problem? Pulmonary hypertension. Pulmonary hypertension. Well, I didn't put the slide in here. Looking in an open claims data set and just looking at the number of claims for pulmonary hypertension, it was well beyond the actual prevalent by like 200-fold the actual prevalence of pulmonary hypertension in the U.S. So you go, what the heck is going on? And it's one of these things where it's a disease that patients tend to be ruled out of. So docs will evaluate them for pulmonary hypertension. They'll generate a diagnosis code for pulmonary hypertension, which is highly justifiable because they did assess it and they're getting a claim for it, but they don't have it. So 99% of those patients do not have pulmonary hypertension. And there's studies to actually show you that is actually the case where they've gone in and looked at charts and such. 99% of these patients do not have it. Yet there are studies out there that have said, oh, I've seen one was the burden of pulmonary hypertension. And they just said, let's look at all the patients that have a diagnosis code for pulmonary hypertension and what's the cost of their health care for the past year or two. And this is the burden of pulmonary hypertension. And now, as an epidemiologist, like digging into this, knowing that what you just presented, 99% of these patients don't have pulmonary hypertension. And so, you see, they went through peer review, but these are kind of things that, still happen. And it's kind of things you'll pick up some of that understanding as you dig in and really ask the right questions around these data sets. Key thing with closed claims. Yeah.
The fact that what was observed in that claim, it was the visit. So during that visit, indeed, the person was
They were assessed.
That doesn't mean that you are observing that person.
Yeah. It goes back to what is the origin of the data? This data is used for billing, and it was appropriate. The quality of that data was right. They actually were billed for a visit where they assessed pulmonary hypertension, but it doesn't mean the patient has pulmonary hypertension. Yeah.
I mean, the discharge will say the diagnosis will not be in that case.
Yeah, but in a claims, you typically don't have access to the charts. So all you have are the diagnosis codes. they're not in the hospital. It's done by outpatient. Yeah.
When the patient was visited and the guy assessed and they said, "Oh, that's.
Yeah. Oh.
There are other separate rule out, just have to work with someone.
Yep. You work with a clinician and say, okay, well, if they did have pulmonary hypertension, what would they have done next? Is it a particular chest X-ray? Is it some scan? And then if they were positive, would they have treated them with something, or is there a treatment? And you create this algorithm that matches the clinical practice pattern and assessment pattern to say, all right, if they actually were assessed, if the result was positive, if they figured out that they had pulmonary hypertension, what would they do? You apply that criteria to it, and those are published as well. And there's a couple of different ways you could do it. It increases your positive predictive value up to like 85-90% on these things, and it drops the patients down. You have way less false positives. Yes.
So in that example, so that the assessment is going to be a diagnosis.
For pulmonary hypertension, yes. Yeah. I mean, if they did a procedure there, then the procedure code would be there. It would just be a separate line item.
Assessment itself.
Yeah. So like, you go in and talk to you go in and you go into urgent care for pink eye or something like that, right? There's going to be, I don't know what the clinical term for that is, but you're going to have a diagnosis code for pink eye. That's what they treated. There's no procedure, even if they did something and flushed out your eye or whatever, unless there's something that would generate more money for them to get reimbursed, you're not going to see a procedure code in there. Yeah. 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 Well, CPRD is an EHR. We're talking about claims right now. So it's a different coding schema. It depends on what in the current ICD-10 schema, if it has, pink eye confirmed or pink eye evaluated uncertain, or whatever it might be. Like there are different codes. Oftentimes they're not going to be that specific. It's just, and they're going to get paid the same whether they actually had it or they didn't. They're going to get paid for that office visit, and they're just putting in usually the most common or most hopefully most accurate code for it. Yeah.
That rollout. I know a lot of times when patients about patient kind of claims.
Yeah.
Yeah, that your pH example, would that have increased your sensitivity?
Yeah, it does. Yeah. Yeah.
I'm just wondering if her pH.
Yeah, and what she's saying is, and that's more for chronic conditions. So if you're, oftentimes if you want to increase your, the reliability or your positive predictive value of these, you may require two codes to say, hey, like for atrial fibrillation, I think it was, 2 atrial fibrillation codes at least 3 months apart or something to that effect, and then other combinations in there. It then helps assure you that the patient, not only did were they seen once and got the code, they came back again with treatment and or further assessment. So they're much more likely to actually have the condition of interest. Yeah.
So one way to do it is to compare diagnosis and not like separate those and like we have a short diagnosis of the use the testing that you have to get paid. So you can separate the code that way and just do the one thing, we're not associated with the testing.
Yeah. And it's funny, years ago, we got really excited here at ICB, and we're doing all kinds of validation algorithms for claims. And we did it primarily on ICD-9 codes. And now they changed the schema to ICD-10, and we're trying to replicate all of them. Everything doesn't port perfectly. Feel free to cut me off whenever. This is
all these topics are
Yeah.
going to get to in the validation.
Yeah. So I want to talk about closed versus open claims, because you're going to run into these options, and you're going to have people pitch things to you that as a claims data set. But there is a huge distinction between a closed claims data set and an open claims data set, and what we should be doing with high science here as epidemiologists. Claims data are, and you've heard Kevin use the term, they're adjudicated. These are claims that are sitting with the health plan. They've been reviewed. They've been paid. They are going to a health plan, say sometimes an employer. Sometimes the data is coming where the source we're getting it from is from the employer, but it's health plan data as well. It just happens to come from that source. It includes the enrollment information for all patients. And this is the key thing. We know when they were covered. We have an observation period for these patients, right? We know when we can start. We know when we should end. And everything in between those 2 points, theoretically, if something happened, we should see it in there because the insurance should have covered it, right? There would have been some sort of billing interaction. If there was a hospitalization, an ER visit, a prescription, this should be in there. So that's super key. Yes. Yeah. Because they're eligible for care. So, and they've paid for their insurance. So they, it's,
I do.
yeah, it's frustrating that we're paying for something we don't use, but for our case here, you'd be in there. And those are great. You're not going to, those people aren't going to add a whole lot when we're looking at particular disease cohorts, but they do help a lot when we're looking at overall disease prevalence in a general or at least an insured population. So the key here is the observation period, defined start, defined end, and that assumption that if something happened, we should see it. And more importantly, if something didn't happen or we don't see it, I take that back. Man, I thought I was building up for something there. If we didn't see it, then it didn't happen. That's the assumption that we really want to be able to go after. So not seeing it, it didn't happen. Now, it won't include third-party payers, cash payments, medical care that didn't get submitted for reimbursement. So it's not perfect, but the vast majority of it should be there. What are open claims? And I will tell you, I actually worked for now 2 companies that were tied to large open claims data sets, IQVIA, so the old IMS, and these open claims were used primarily for market research, brand teams, understanding drug patterns, switches, things like that in near real time. And the other one was Symphony Health Solutions. And it's funny, that's another reason why I don't use company names, because both of those companies previously would have been known as IMS, SDI, Walters Clore, NDC Health. Like the names change every 3 years here. So either because of acquisitions or because they think it's time to rebrand for some reason. I don't know. I could never get an answer as to where the heck was this data coming from? And there was always these gray, wishy-washy sort of answers. And I finally tracked down insights when I was at IQVIA as to how this works, because these databases lure you in with these hundreds and hundreds of millions of patients, and the idea that 90% of all retail pharmacy data is included in here, and wow, this seems really great. It's got outpatient data, it's got inpatient data, but it doesn't have all of the outpatient and inpatient data, right? So where does it come from? I did finally get an answer. Well, it comes from practice management systems and claims clearing houses and switches. And I was like, okay, well, that doesn't help me. What the heck is that? I'll get to that on the next slide. But that's the vast majority of where this comes. And the key part here is that all of that information, everything in these open claims data sets, comes into this data set well before it ever gets to the healthcare provider. I mean, not the healthcare provider, the insurance company. They're not adjudicated. All of this information is being picked up on its way to the insurance company. So, and it's picked up via various different ways and then cobbled together. It is near real time, which is great. So as it's happening, I used to just pan this kind of data and just hammer away at it until the pandemic hit. And when the pandemic hit, and I couldn't wait 9 months for my perfect data, I found ways to leverage open claims to get insights as to what the heck was going on with COVID. So there's some benefit to it, but there's so many caveats to it. There's no enrollment data. We don't know when patients started or when they end because this isn't insurance data. We don't know, we don't have an observation period where we can be confident that if something didn't occur or something, if we don't see something, we don't know whether it's because we didn't get it or whether it didn't happen. So there's big problems epidemiologically when you're looking, when you want some sort of reliable incidence rate or even a prevalence estimate. The beauty, though, is all payers are included. So it's not just limited to commercial claims. All payers and uninsured are coming in through here because this data is being generated oftentimes at the point of service. Yeah. Yeah. Oh, yeah. Could be. Yeah. These look like regular claims data sets that I talked about, the closed claims. They have inpatient, they have outpatient, they have prescription. They'll be missing that enrollment data. So if you're working with the data set and it doesn't have enrollment, or you can't apply the enrollment criteria, or the vendor you're working with or the partner starts getting tricky and saying, well, we could proxy enrollment by this, and you're working with an open claims data set. So just make sure you look at it with a different lens. This data can also be, linked across other data sources as well. It's usually tokenized. The big providers right now are still IQVIA, Symphony, and Health Verity. All of those three have very large open claims data sets. Yeah, sorry, I'm throwing a buzzword. I think we'll hear probably more about it later on for data linkage. It's a way to take a unique patient ID, create it's basically almost like another unique patient ID that is then you use the same process across different data sets to create a token. Data set A, a token in data set B. You say, oh, there's the same token. That's the same patient. So now I can link these two patients together, and I can have all their claims data, all their EHR. Yeah, de-identified, and such. But then also you also have potential for duplicate data to exist when you're doing that here as well. Yes. Mm-hmm.
Have no idea if I'm correct in some cases that the patient would actually receive that script.
No, these are going to be all filled. These are going to be filled.
So this is still dispensed.
Yeah.
Where you're thinking with the problem with
that's an EHR issue. Yeah, we'll get to that in a second.
Then it was written.
Yeah.
You don't know.
But you know what? I will point. Yeah. So this data comes directly from the PBMs as well. So in the closed claims data sets, typically the prescription data you have is just what was filled and the information around that prescription. One other beauty here, especially for health econ folks, is that these open claims typically have more data from the pharmacies about abandoned medications as well. So the ones that were called in by the doc that the patient never picked up, and oftentimes may even have information as to why they didn't fill it. You also will see some of the brand called in and switched to generic and things like that. You'll be able to get more details about what's happening in the pharmacy than you would in any kind of closed claims data set. So, okay. So what is practice management system? What is a practice management system? Because this one, I wasn't familiar with this, even after being in this industry for so long. It is software that the medical practices use. They do it. It includes everything from scheduling of the patients to patient data organization to handling their billing and claims processing. So the things that occur in that the physician's office, typically physician's office, some hospitals may use this as well. And you will see that in the open claims, while the prescription data is voluminous, the outpatient data is maybe about 60% of those patients, 50-60% will have outpatient claims, and maybe like 20%, 25% will have hospital. So it's there's definitely a degradation over there. But the information that's in this software is what's being provided, or one of the contributors to the open claims. The other are these things called claims clearinghouses or switches, and I've heard these terms as well, and I finally figured out what this is. Anybody in here actually know what these were before I'm walking through this? No? Okay, good. You're learning something today. If you think about a physician practice, and they go, okay, they see all these patients in here. They take all these different types of insurance, right? They have to then submit these claims to get paid for the service they provided to the insurance companies. Now, these open claims data here is picking this information up through these clearinghouses or the switches. These clearinghouses basically take they'll take the data from physician practice X, who have maybe 300 payers that they need to submit for, and they got to fill out the forms. And if you've ever worked with an insurance company and tried to submit a form on your own, I don't know about you, but I tend to get rejected too the first 2 to 3 times, and then your persistence finally gets you through. This company or these clearinghouses will help to maximize the success of pushing your claim through. They get the format right, everything's filled in correctly, they know the process to do this. The physician practice can send all of their 300 different payer type, claims to one person instead of to 300 different insurance companies. And this clearinghouse will do all of the work to get it out to all of them and funnel that money back to the physician practice. So they're saving them a ton of time and increasing the probability of not getting their stuff rejected. So the error rates typically on paper claims 28%. Clearinghouses reduce that to about 2 to 3%. So you can imagine docs are going to like this. They'll pay for the service because they're going to get their money a lot faster and a lot less headache. Significant efficiencies. And so when they're sending this on, these clearinghouses, they're getting this information to prep to send to insurance companies. That is then being diverted into an open claims data set, being combined with the physician practice software and being combined with prescription data from PBMs and other ways as well. And a PBM, just realized I'm using another term. It's a pharmacy benefit. Yeah. So a pharmacy benefit manager, like an Express Scripts or something like that, where they provide prescription coverage to supplement a lot of the other traditional medical insurance. So that's their specialty. So we have enrollment data and closed claims. I think now at this point, repetition is good because you now believe enrollment data is good. You need an observation period, right? We need to know how long we follow these patients. We need to know that when we don't see something, we can make that assumption that it didn't happen. These don't have enrollment data. So what happens in open claims? Oftentimes the researchers who are working on open claims will say, well, I'll proxy it. Let's look at when we see the first claim and then we can end at the last claim. Or if the patients have at least X number of claims within a certain period, we'll call them active. And they'll provide proxies to try to simulate activity or that these are patients who should be contributing data. The problem is you see 2 observations. You don't know whether that's 2 out of 2 or 2 out of 100 because patients could be going to lots of other healthcare facilities that don't provide data to these the practice management software, or docs that don't use these clearinghouses. Requiring medical activity could introduce bias. The question to the back about the healthy people. Well, the healthy people aren't going to show up here because they didn't go to the doctor. The only reason they would show up in the practice the practice management software is if they actually went into the office and had a visit and something that would generate a claim. And they don't have anything going to the insurance company. So your healthy people won't be in this data set. You may see some that are pretty healthy. Maybe they have a claim once a year for one prescription or something like that. And, the question then is how you apply these criteria to proxy your population that are active and what bias that might introduce. Presence of data doesn't equal complete data. Open claims, in my mind, are very similar to conducting studies in EHRs, where you have to think through, because the patients are here and they're continuing to go to this particular provider, does that make me comfortable that all of their care relating to this condition should continue if they continue with that same provider? Or is it possible that they're going to go in and out and go find other providers to help with that same condition? That could help here. It could help with your assumptions of complete data. The problem is that practices, they change practice management software. They change use of clearinghouse as well. So it may not be that reliable. I found this one here because I want to show both sides of the story where it doesn't, like, sometimes there might be benefit in using both at the same time. And I had never really heard of this until I saw this study. where they used closed claims to look at statin prescription use and adherence and persistence with the, or I guess persistence, not adherence, in a closed claims data set. And then they put open claims on top of it and said, okay, well, let's see what happens when we add something that is really strong in prescriptions to a closed claims data set that theoretically should have everything. And what they actually found was that there were a lot of statins missing because so 20% of the patients had at least one missing statin after their index date. 15% of the patients ended up getting misclassified as new statin users, and the medication possession ratio was higher in the combined data set. So they're able to fill in the gaps with some of these statins. And the big issue here was that there was missing data because the patients were getting the statins covered by an alternate third-party program, or they were getting coupons and discount cards. So if there are products out there, it's probably not something you're going to see, for all products, but for something like this was one where there was a fairly decent number of patients that were finding alternate ways to get free or reduced,
So this is
medication.
interesting. GoodRx, a lot of different programs. So this is where the instance of a database matters, because if you were using the Optum database or the Pharmacoepidemiology database pre-2017 versus today, it's a big difference because healthcare is evolving rapidly.
So I want to save some time here, but basically open claims really, really strong if you want something near time. I would use it almost more for hypothesis generation than testing. Because so oftentimes, especially in pharmacoepi, and we're looking at incidents of safety events, the incidence assumptions are not going to hold up in an open claims data set. You need something closed claims. But again, like I said, for the pandemic, I couldn't wait 9 months to get insights. We had to use the best we could and then figure out, all right, well, how do the caveats potentially influence our results? But I learned long ago never to say that there's any bad data sets. There's just bad pairings of a data set to a research question. And if you ask the right research question, the open claims could be a viable support source. Yes. I'll tell you honestly, from my perspective, I feel like a lot of health authorities don't understand the difference of open and closed claims. Some of them are pretty educated. Others, I have been stunned that they would accept open claims at times and used for even some of their own decision making internally. I don't know if others have perspective. I can only talk anecdotal. Yeah.
Great.
Yeah. So some of the folks who sell open claims, they don't go into the kind of detail that I just provided as to how they're different. They just sell the benefits of it. And hence I'm just trying to bring a little dose of reality here to at least, pressure test this. They might be good for something. If it's incidence-based stuff, if you're looking for, especially like if you're looking for, and you want to be complete in picking up every event that occurred, at least as many as possible. And then for all your health economic colleagues that want to jump on the tail end and go, well, then what's the cost of this? If you're missing a lot of hospitalizations, it's what good is it, right? And if you're talking about rare things, if you miss even a couple of events, you could really skew your incidence rates on these things. All right, let me jump into EMRs real quick. Anybody here who's worked in EMRs before? All right, good. EMR, EHR, same thing in my mind. If there's a differentiator, I apologize. I would use them interchangeably. They are basically paperless digital versions of patient chart folders. So back in the day, like, I don't know if you're as old as me, you could go, I got my chart one time from a doctor and they handed me a folder that had all of this paper in it and literally had color coded, things on there with the REY from my last name, and then every paper printout of everything that was in there. Because I was physically taking it to another physician, back in the day. They didn't have ways to go back and forth. These days, more than 80% of the U.S. office-based physicians and over 96% of U.S. hospitals are on electronic health records. So, and a lot of them talk to each other as well. The data is, from your cardiologist might be sent over to your pulmonologist, to your oncologist, et cetera. They use it to improve quality of care. They're keeping track of everything that they're doing with that patient. They've got the information in there that allows them to make effective clinical decision-making on these patients. But we like to leverage it into an analyzable data set, right? It's got a lot of clinical detail. It's got a lot of information. If you've seen one EMR, you've seen one EMR, and they often lack standardization and completeness. I actually got a raw oncology EHR data set probably 15 years ago. 100,000 patients in there. We're super excited. But it took us 6 months just to clean it up because there's misspellings, abbreviations. Like you can't just get in there and apply code. You actually have to clean the data set first because it was not research ready. You get a lot more information on patient demographics. I noted the limited patient demographics in claims. In here, you often get race, you'll get height, weights, you can calculate BMI, you'll get it longitudinally each time they come into the office. You may have information on alcohol use, smoking history, geographic location, genomics, family history, all of that kind of information. You'll also pick up the billing and insurance information in here as well. The other big upside, though, is that this is not driven by an insurance company. So you'll get everybody who comes in the door. It's point of service. Think about what you're going to see in this EHR is from the people who are coming into that physician's practice and or all the practices that might be linked. Sometimes there's multiple sites. There might be multiple brick and mortar facilities that use one EHR system. And it could be just a general practice. If you, there are ambulatory EMRs out there that are primarily general practice data sets. You'll see what happens in general practice, but you won't see hospitalizations in ER. There are health system EHRs, and in those you might be able to track patients across the whole health system. You might be able to see their general practice data. You can see their cardiology data. You can see when they were hospitalized, their ER visits, etc. Yes.
Talking about weight, I think there is an example that to me is very useful. So I some like 10 years ago, there was this paper that found that being thin was associated with all possible evil from primary care medical record that I think it was CPRD. And then the reason is, why would you record during a primary care visit? Why would you record weight? Unless if the person is obese, this is why you record weight. You record it regularly, so it's not associated with anything particular. You only record the weight of a non-obese person if there is something else. So what prompts the data again is really determinant. And
that very well could be true. And I think it seems to be common practice in a lot of U.S. Physicians' offices now that when you come in, they weigh and measure your height like every single time. So,
what prompts the recording of a weight? Is it a standard thing, or is it not?
So we have HEDIS measures and other things and quality of care metrics that really need to be understood to understand the provenance of the data. If my insurer went and audited and requested a chart of my University of Pennsylvania medical record and found that I did not have a weight when they paid for an office visit, they'd say I want my money back. And so because of that, our data, the reason EMR exists in the US is because of the fear of loss of payment. And to document care and provision care.
But your point holds up though, Rosa, in other like for example, I looked in I was working in one data set where we were looking at ADHD and we were looking at growth and maturity issues. And so we found that like 20% of the kids with ADHD had assessments on this validated scale for growth and maturity. But it was highly skewed towards kids that were not hitting the metrics for their growth and maturity. They were assessed and documented that they were lacking in their, or behind in their sexual maturity and growth. So it was highly skewed. And I think what you're saying definitely holds up for something like that. You get your medical data. You still have diagnosis codes, but you may have textual description, or you may have different ways that they've defined the variables in an EHR. You'll get medical treatments, drug prescriptions. Somebody asked before about drug fills versus drug prescriptions written versus drug fills. Here you get the prescriptions written. You likely are not going to have the drug fills unless this is linked to some sort of claims or prescription data set. but you may get more detail on the dosing, the duration, the instructions of use may be sitting in there. A lot of laboratory test results in here, especially the standard panels. You get blood pressure oftentimes because it's measured there and it's fed directly into the EHR. You may also get more exotic clinical data, so treatment response, genomics, disease severity, things that you wouldn't be able to get in a claims data set. And this is less standard than in claims data sets. So when you're evaluating an electronic health record data set, you do have to really pressure test it and ask about all these different key variables that are going to be important for your research study, how complete they are, how they're defined, because what you tend to get from the EHR, you're getting, the folks who are going to be selling you electronic health record data, they're getting the raw data most likely somewhere, and then they're putting it into a research data set. They may be making decisions on what data from the raw EHR gets put into the data set that you get to work with. They may be making the decisions, like I'm thinking back to like the American College of Cardiology has a Pinnacle data set, cardiology data set, and they specifically drop all drug brand information out of there. You just get drug class, and but you might have more detail on the condition of interest. And, because they don't want their data being used to compare one product versus another. So there are decisions there that impact what you can do with this data set, and may have unintended consequences when they're dropping data off or predefining data in a particular way. I mentioned the prescribing and dispensing. You have limited treatment outside of other facilities. I work at Flatiron. We have an oncology EHR. The provenance for this data is unlike any other. We can get all the way back to the original, to the initial patient, and it's phenomenal, high quality, top notch oncology EHR data. But we fall apart if you want to look at incidents of emergency room visits or hospitalizations, because we're getting the data from the oncologist. We're getting the data from the oncology practice. We have phenomenal data, and I'll show on another slide here too. We not only does that data, when it comes in, we have the raw data, but before we create the analyzable data set, it goes through 2,000 nurse abstractors to fill in the gaps, apply definitions for line of therapy and progression, and links to obituary and death data. And so, you have to understand how the data set was built, and hopefully some of these things and some of the references that we'll note in these slides will give you, some of the ammunition to push back and pressure test the data set to figure out, does it have what I need, and was it collected in the right way? A lot of stuff not always entered in EMR, disease progression, laboratory results that might not be on a standard lab panel, complementary, supplementary care. The data consistency varies across providers within the EHR oftentimes, if they're able to do that based on how based on the data entry, but then also across facilities and such, so within and across. If you can get free text, it's a gold mine. You'll notice a lot of the EHR providers are applying AI, ML, also artificial intelligence, machine learning, natural language processing to dig into that text to be able to make things more automated and fast. But the free text that's available from one to another could be zero, could be some, could be all. And you can imagine too that if you're building algorithms on top of none, some, and all, those algorithms are going to have different qualities associated with them as well. But also that free text data, being able to go back and add a new variable, being able to go back and confirm or validate that a safety event occurred. This is where, this is one of those real differentiators that help increase the quality for particular research questions. Data lag's a lot shorter. I mean, you can see it's pretty much real time. You're not going to likely be able to get real time EHR data, but you could probably work to get monthly updates or weekly updates, depending on what your question is and the need for it. It's got the single site. You got to figure out how to answer the questions, whether it's through linkage or other ways. If you want to ask questions about care that's occurring outside of the EHR, or it might just not be available. I kind of walked through this before, the source EHR, just kind of pointing out how it could vary by EHR provider. This one is sort of brought in all the things that the Flatiron one does, but you can go back to the source EHR. You can, the source EHR on that top box has all your your core data. It's got your diagnoses, your demographics, your drug orders, your visits, your labs, all of the key stuff in the EHR. And then there's a question of what the data provider will do with that. Do they define it for you? Do they just pass it through in whatever raw form it is? They usually will at least have to make sure there's no patient identifiers in there or there's some problems. Then you have the unstructured EHR, physician notes, radiology, pathology, discharge notes, any sort of text. What's being pulled out of that? Or can you tap into that with a particular research question? Some vendors only have the EHR data that has been sold to them that they're reselling and they can't go back to the source. Others own the data because they're tied to that source somehow and can go back and supplement and expand. And then can you take that data and link it to things like mortality data, genomics, imaging, things like that, or combine it and or be able to go back and identify that patient and maybe conduct a prospective study where you ask the patient a survey about a PRO, or you ask the physician to conduct an assessment of the patient in real time. Or if you need images at time point A and B and they're not part of standard care, maybe you are able to use your off-the-shelf EHR, but then you supplement with just those 2 data points in a very focused prospective study. All right, I think I've gone through the pros and cons. I've probably well past my time here, right? Yeah, sorry. Although there's a lot of questions, so I'm going to blame it on you guys. There's one other one more recent on selecting optimal data sets, really fitness for purpose. If you guys haven't heard this term, fitness of use or fitness for purpose, you may be either new to epi or living under a rock. It's a buzzword out there now, along with tokenization and external comparator arms and things like it's right in there. So it's basically taking your research question and finding out whether the data set that you want to propose actually matches. Is it fit for use? I'm going to take the term that I hate, Rosa, is regulatory grade data. I think that is entire nonsense. There is no data set that is on the face regulatory grade data. It could be poor quality data, and then it's just bad for everything. But if the quality holds up, if it's valid for its intended purpose, the question is whether the research question you want to ask to it and use it for allows it to be fit for purpose and thus regulatory grade in that sense. There is no data set off the shelf that is regulatory grade for everything you want to ask it. So I think that term is nonsense. And then there's I don't know. That was my example. Oh, now you got to look at this guy. All right. So if you have additional questions, you want to chat about data, I'm happy to do it, and you've got my contact info there.
So we can talk pros and.
All right. I know that was a quick break, but our first activity back will still allow some people to come back and sort of gather. So this is what I like to call pharmacoepidemiology improv. Quick, give me a specific aim. Give me a database that can answer the question. Or quick, I need a target, or I need an exposure. I need an outcome. I need a comparator. I need a database. I need a name, right? So what is the question? So we'll start with what is the question, because that's what Brian Strom always told us in every one of our meetings was start with the question. So can I have somebody from over here just shout out an aim?
Characterize hyperglycemic justification in the first year after initiating full anti-hyperglycemic therapy among adult patients.
Okay, great. So a lot of buzzwords out of there to take away. We definitely need diagnosis, right? Because we're going to need to be able to do phenotyping to get at an indication of diabetes. We're definitely going to need drugs because we're going to need to follow and characterize these people. Does anybody have a database that they think can answer that question? You don't even have to have a card. You can make one up. It's okay. All right. Can Premier answer that question? Premier, a hospital-based data resource? Probably not, right? Because it's going to be like, I might have a DKA episode, a diabetic ketoacidosis episode, but I don't have what happened before and after, and I certainly don't have the longitudinal follow-up. Database? What? Yep, sure, right. So CPRD plus the HES would help with some of the hospitalization type follow-up for characterization. Yes, excellent. Does everybody see sort of how the game's played? Let's get one other aim, and then we'll... Somebody have a green card. All right, so pregnancy, great. We haven't spent a lot of time in pregnancy. There's a whole class on pregnancy. There's also tons of workshops here at the conference on pregnancy, which adds yet another new dimension to all of this with regards to linkage and follow-up and all those types of things. But pregnancy, very important thing. So would the VA be a good database for this? No. Number one, lots of men, although there's tons of women in there. But number two, pretty old. Right. So wait, you said non-pharmacologic. So let's think about pressure test, that word non-pharmacologic. I might be thinking I need some more EMR type data to sort of get at what lifestyle factors or other types of things may have been discussed or talked about. Does everybody see how I'm thinking? Okay. And now you could give me your PhD aim and we'll do the same exercise and help you find. Okay. All right. Yeah. Oh, if anybody wants to. Any other aims? Anybody else got a burning aim they want to just talk about? You want to go? Perfect. And that's going to be a great segue into this. So talking about developing algorithms to get at constituting incidence of disease is going to be a big piece of what we're talking about. Your question could be answered in EHR or claims with all the caveats that were already talked about this morning. Okay, great. So I am representing Dan Beachler. I'm going to do the best that I can. I've obviously heard this lecture probably about 3 or 4 times, 4 times probably. So I should be a good substitute. I have done a bunch of validation studies. So my conflicts of interest are I work at Johnson & Johnson. I used to work at HealthCore, which is now Carelon. And I think Dan then has his disclosures on the next slide. And we're going to start with this, why we validate. Anybody? The data said it must be true. Exactly, right. So we validate to understand if our sources of information are reliably capturing and telling us the information that we intend for it to be there. We're going to talk about why we validate. We're also going to talk about, is a previously validated algorithm sufficient for this new study that I'm doing and why? We're going to talk about some approaches and the mechanics of validation studies, and then we'll end with a little bit more of the advanced side with regards to algorithm development and some quantitative bias analysis. Much like this entire day, obviously you could almost spend a 4-hour class on just this in a PhD type pharmacoepi course. So much of this is leading you to sort of resources to go and learn more. So you'll see lots of references. Don't have to take pictures of slides, although you can. They're all available on the ISPI app. All 4 slide decks now are available in PDF there. Lots of references here to pull and go and get more information. And I'll plug early that the validation to correct outcome misclassification, there was a commentary that Steve Lanes, who's here, and Dan Beachler published in PDS. A lot of this talk builds off of that commentary. And they've already seen some of these references, the guidelines and a couple other references. So there's some overlap to the talks as well. So why we validate? This process of establishing that a method is sound or that data are correctly measured. There are mechanisms to validate methods. We're not going to be talking about those here. That's an advanced topics type course or more methodologic piece. We're going to be talking, is the data correctly measured? And so why are we validating, right? So information bias, right? We want to avoid exposure or outcome misclassification because that can really diminish our overall study validity, right? There are many previously developed algorithms. There is no true phenotype library. I've been looking to get a phenotype library card. If anybody knows how to get a phenotype library card, let me know. I'd love to check books out, check books in. This world is changing, evolving rapidly with regards to the development of these algorithms and the sharing and portability of some of the coding algorithms and the thinking. And why we validate? Because regulatory agencies strongly recommend that we validate, right? So when regulators tell us to jump, we say how high, right? Because we want to make sure that we are compliant with the safety reporting of our medical products. All right, so what algorithms are imperfect? There are false negatives. Patients don't seek care. How good is a epistaxis, nosebleed algorithm? How many people have had a nosebleed? How many people have gone to the doctor because of that nosebleed? Right, so that doesn't generate. Now, if your nosebleed is serious enough that it warrants medical attention, it's potentially real, but it also then could lead to our abilities to make sure that event really happened. Diagnoses are incorrect. We already talked about the rule out diagnoses. I've got to just give you this diagnosis of colorectal cancer because I think you have it, just so I can get the colonoscopy paid or something like that. Okay. Now these are changing in the way that evolving and coding practices happen, but diagnoses are coded incorrectly. And then there's the false positives. You have a diagnosis in the code, but it was recorded incorrectly. I think you have disease, but you don't have disease. So that was my example of the rule outs. And the false negatives, certainly there's the missing data. All right, so this is the slide to print and tape next to your computer, because inevitably you'll be on a call and you're lost, and it's just easier to go, wait a minute, are we talking about sensitivity? Are we talking about specificity, right? So this is the slide to print. If you haven't seen this slide in your EPI coursework, this is the one to print. Yeah, so take pictures of this one. Yeah. That one, right? So, and remember, your stats people may flip this, right? But predict, we love 2x2 tables, right? We love 2x2 tables, right? So you've got the test or the predicted, the algorithm, the claims tells you have disease or doesn't. And then true cases is some gold standard told you that you have disease. Now, I'm a purist. I don't even believe a chart recorded systolic and diastolic blood pressure, right? The only gold standard for blood pressure is stick a probe in my juxtaglomerular apparatus and ask my kidney what my blood pressure is, right? That nurse could have messed up, right? And recorded it wrong, right? So I want to validate the nurse. I'm kidding. I've gone to the extreme here, right? But think about it. There's gold standard, and then there is the underlying biology. What is that cell? You know, the day that you wake up and say, today's the day I'm going to have diabetes. You know, I want to get inside and put a probe into the pancreas, right? A HOMA IR, and understand that today is the day that I had diabetes, right? To get at incident diabetes, it's really the day that I manifestly presented to a clinician to get it diagnosed. All right, so we live in this imperfect world. I guess that's a general statement. We live in an imperfect world. But we have sensitivity and specificity, and this is the place to play with a rather large Excel spreadsheet someday and go, okay, what if my sensitivity and specificity was differential or non-differential? You know, all of those types of things you can play with in your own within your own data worlds, and understand how that would change your odds ratios. And we're going to go through a bunch of that today. Let's live in a world under certain assumptions. Let's live in a world of non-differential, right? So we often say, the PPV is non-differential. The misclassification of this outcome is non-differential between exposure and outcome. And even in that world, we often say, well, as long as I have a PPV over 70%, how bad could it be, right? I'm a little off, but it's not that big of a deal. And that's for large purposes, as long as you assume non-differentiality, that's true. Because what's the difference between 1.5 and 1.6 or 1.7, right? Your conclusions may still really be the same. And even I would argue at the higher levels, relative risk of 4, you know, what's the difference between a relative risk of 4 and a relative risk of 5? You would say, well, I already raised the flag of a signal or a problem or a concern. There may be some precision estimates and thinking about the 95% confidence intervals around these. But most of my clinicians, when I talk about relative risks greater than 4, they're like, why did you have to do a study for that? Don't we know that? You know, so temper expectations here. So this is an old paper, 1983, and this is the major assumption here is that we're living in a world of non-differential PPV. But remember, our goal here is to minimize bias due to misclassification. And this involves these trade-offs between sensitivity and specificity, and we'll get into that. Right? So you can have a highly specific algorithm that finds people who really, really have disease. They got to have 6 diagnoses, treatment, all of this. That's great. They really have disease. But then if I'm in a surveillance aspect where I'm just sort of like really understanding, do I have a safety position here? You may be wanting an algorithm that's more sensitive to pick up non-cases. All right, non-differentiality, question mark. We live in that world where it's non-differential. So we're okay, bias towards the null. Move on, right? We've seen those limitations sections. We may have written some of them. Okay. So how might this accuracy of case ascertainment depend on treatment? Does the exposure lead to any additional healthcare outcomes or healthcare encounters that may lead to diagnoses? Is there labeling that may cause attention to possible problems? Or, like, let's see, atrial fibrillation among osteoporotic patients who take the bisphosphonates. So the bisphosphonates can kind of get stuck. They're big tablets. They often get stuck in your GI. Well, what happens if you show up to the doctor's office complaining of chest pain? What happens? Put leads on you, right? Oh, look, you have atrial fibrillation, right? Well, no, you would have picked that up if you slapped leads on everybody, right? So we got to think about, the propensity to seek care, all those things that we talked about with regards to the databases. We also have to think about in terms of the patient populations and our exposure and unexposed populations. Okay, so non-differential biases towards the null. This is this quotation. Not always true, and we're going to show that here in the next slides. On average, non-differential association of a dichotomous variable will bias results towards the null. Here's a paper from the Sonder Greenland groups to really solidify this. And so we'll talk about this in a little bit, but I want to switch gears a little bit because often we sit there and go, well, look, validation studies are expensive, right? Got to pay for, yes.
Yeah, in terms of the non-differentiality assumption, I think it's also important to highlight that this is a discussion that you make if relative risk is your measure. But when you are in relative difference, then it doesn't matter if this is non-differential or not, you're still misclassified. You're still really, really biased.
Yeah, hold the thought because we're coming right back to that point. Often in a world, we live in a world where we're like, I'm a PhD student. I've got to get my master's thesis or my PhD dissertation done. I'm going to borrow this algorithm. It has this published PPV. I'm going to run with that, right? Maybe it was done in MarketScan and I'm using Pharmetrics, or it was done in Carelon and I'm using Optum, or it was done in CPRD and I'm using Thin. I don't know, right? So that's usually a place to start. And the other place to start is regulatory guidance sort of recommends this process, right? We already talked about the debate. This is where the debate comes back in. Should we validate everything? Validate exposure? Should we validate covariates? Should we validate the incidence of the indication diagnoses? We could certainly spend a lot of time validating, right? And well, that's why I'm here. So we need to think about this concept of, if we're going to use this operational definition, we should think does this prior study, does that operational definition really fit the same data source? Am I really using it off the shelf the same way? We read, and how many people have read a paper? We use the following previously published algorithm, right? How many people have then gone and checked to make sure that the supplemental appendix A that contains the code lists matches reference 19's published validated algorithm? Anybody? No? No? Okay. You guys like your weekends. Okay. So I think we've got a poll question, which I didn't set up the whole polling question. So we're going to just do this like non-millennial old school method here, right? Which performance characteristics are the most transportable across databases? Sensitivity and specificity, transportable. I see some hands. PPV and NPV, I see some hands. All are similarly transportable. I see some hands. Okay, so it's A, sensitivity and specificity are transportable. PPV is not. So PPV is not transportable because PPV is very dependent on the prevalence of disease. So I found this great validation study. It was done in US claims and it was done in Medicare. Is that transportable to a commercially insured population less than 65? Probably not, right? Because of the prevalence of disease. Don't take my word for it. Take math's word for it. And again, feel free to plug these into Excel and just play and see for yourself, right? Pick a bunch of PPVs, pick a bunch of sensitivities, specificities, and have fun with this. Although I think all of that is actually done in this 2020 paper by Fox and Lash. So great resource to pull to really begin to think about how prevalence of disease. And you can think about that, you know, a very small prevalence. You're not multiplying much here. You're not multiplying much here. So that's basically 1. And you're not really subtracting by much. So, right. So you can do that. You guys can go through the mental exercise of recognizing how prevalence impacts PPV and NPV. Yeah.
Well, that's not the reason, because there are also formulas that do the opposite. So from
Agreed.
a mathematical perspective, they are completely equal, PPV and specificity, and then they are exactly the same. The reason why
They're dependent on prevalence, though.
but also I mean, what does dependent mean? I mean, if you talk about the mathematical dependence, they are equal. They are perfectly symmetric. What is not symmetric is that sensitivity and specificity have a causal interpretation. So it's being sick that causes you to be captured, or being healthy that
Understood. I am really, really good at developing a test that says 5-year-olds don't have Parkinson's disease. I don't, you know, my PPV for that is like, I can just look at it because of prevalence, right? Or NPV. So there is a dependency on the prevalence of disease with regards to the portability of test characteristics.
It's the cause of it.
It is both, right? It is both. I mean, the math is the math.
Yeah, the math, you can reverse those equations and put sensitivity on the left and the PPV on the right. So from a mathematical perspective, and I sent you, I think, a paper, you just see that there are laterally. So the point is that if you have both PPV and NPV, you can calculate everything. You can calculate specificity and you can calculate sensitivity, which then you
Agreed. If you have both, but often we do not have NPV. All right. We're going to get to that. Yeah. So there's lots of papers, and this is an oldie but goodie, 2012, 10 years old, but this is Mini Sentinel, now Sentinel's systematic review of validated methods. And you can see that there's a few regular conditions that have very high PPVs. When you see a total hip arthroplasty, they have a total hip arthroplasty. When you see a DVT, they had a DVT. There are also many algorithms for health outcomes of interest that we see a lot at these conferences that have inconsistent or low PPVs. Now, some of this low PPV is due to low prevalence situations, but some of it is it's difficult to get at some of these outcomes in our traditional claims-based database sources. There's a lot of lack of transportability, right? Just because, and a lot of it hinges on that things that we've talked about here today with regards to databases. A algorithm developed in the Optum clinical claims data is likely not transportable to your Italian data sources for many reasons. The most prevalent about is around the difference is in healthcare seeking behavior, data recording, the nature of why those databases and data sources were collected, right? But there may be differences across claims data sources. There may be differences across time. Matt mentioned the transition of ICD-9 to ICD-10 and the increased granularity that ICD-10 affords. Study populations definitely affects the inclusion and exclusion, the risk factor distribution, the prevalence of disease, which has the impact on the test characteristics. So poll question 3. A study using an algorithm with a very high PPV, 80%. A has little bias from outcome misclassification. B might be biased from outcome misclassification substantially and in either direction. And then the long-winded one, which makes everybody think, that must be the right one, has little bias from outcome misclassification, assuming that the validation study is valid and reliable, is conducted in the study population or a population with the same covariate distribution as the study population, and the sensitivity is also over 80%. So a rather large word salad. Anybody for A? Little bias. It's over 80%. We're good to go. B might be biased. It may depend. Okay. And C. Okay. So it's B. Whoops. From Dan's discussion and description, and this is because, and I'm going to show you in the next couple of slides where a differential PPV, even by a little bit, can really cause substantial bias in either direction. Rose?
You're talking about relative risk.
I am talking about relative risk. I'm not on a risk difference scale, but you're right. I can put myself on a risk difference scale. We'll have a whole different discussion. 90% of the abstracts and things that are presented here in the next 4 days is relative risk. I totally understand that on a risk difference additive scale, a lot of these assumptions are going to be very different on an additive scale. Yes, yes, yes. Okay. So this is a excellent paper by Newcomer and colleagues in AMIA in 2019. And this table here shows examples of overall PPV and how it may be indicative of this presence and this magnitude. So let's focus on the last row here, right? An overall PPV of 93%, you're thinking that is great, right? 93%, this is a good algorithm, right? If you do a true relative risk, you get a relative risk of 1. Yes, we're on the relative risk scale. Yes, relative risk of 1, I do not have any effect, right? However, when you dig deeper and find out that the PPV is differential between exposed and unexposed, and it's 96 in the exposed, 93 in the unexposed. Obviously, you have a lot more in the unexposed group within this study. Now you observe, when you correct for this outcome misclassification based on the differential PPV, you observed a protective effect. I'm not sure what the discussion here is or what the outcome here is. This is a simulation type piece, right? So here you might have concluded, I have no effect. I don't prevent cancer. Wait, I might, right? So this is an example of where differential positive predictive value across your exposed and unexposed, even small, can have a large effect. Stepping up to example 1B, you can see this is the more classic bias towards the null overall PPV of 93%, but if it was 79% in the exposed group and 93% in the unexposed group, again, the 93% dominating the overall PPV because it's the larger population, you can see the effect that has on the observed relative risk when adjusted. And then the first example is sort of a negligible bias based on 93-94 difference and sort of this similar conclusion. So again, excellent paper to review on quantitative bias analysis, which is actually where we're headed in this talk. So what are some of the approaches and mechanics? How do we do validation studies? So this is stepping back into the database components. Some databases you can't validate because they are de-identified, right? So you can't then go and ask for more information. So questions to consider: what should we validate? What is a reliable gold standard? What are the estimates that we need to get PPV sensitivity, and in what groups to think about any differential misclassification? Exposure. We could certainly spend time validating exposure. Typically, you'll hear us say, well, it was dispensed, it was paid for, it was picked up. I'm not doing a validation study and calling the CVS pharmacy and asking if Bob came in and picked up the medication. Could that be done? It could be. My busy wife would probably hang up the phone and not give you that information, right? But we could validate exposure. And certainly in home infusions and some of our expensive biologics and some of the things that we talk about, does that data exist? Is it complete? We absolutely need to think about validating exposures, right? Home infusions, expensive or even inexpensive inpatient medication exposures. We should absolutely consider spending the time validating exposures, especially when we live in a world of uncertainty. Covariates, really hard to think about all, let's do a 1,000 propensity score covariates, right? And validate all 1,000 of those outcomes. That you're not going to finish your PhD, right? But we should be thinking about utilizing reliable covariate measures to the best that we can, or thinking about sensitivity analysis of how much misclassification, what if all of my non-smokers were smokers, those types of sensitivity analyses that we could build in. Outcome, spend the majority of our time thinking and concerning ourselves with, is the outcome, is the case a case, right? We can sample to improve efficiency. We need to think about random sampling. Are we going to be stratifying by exposure? Lots of questions to ask up front. Yes.
You know what? Nobody ever speak about validating inclusion criteria, which I think.
Yep, could have put it on there. Yep.
We could talk about
Yep.
more because that's
Absolutely.
bias.
Absolutely. Yes, absolutely. What are reference gold standards? So we're going to talk a little bit about some data linkage. One way to do it would be I have this cancer registry, or I have this registry of diseased people. That's another data bank that if I could link with my other data banks to create a data source, that then I could do some electronic validations, right? I could do patient or provider surveys. I could request medical records. You should see those two bullets as being expensive, right? Because now I have to go back to a data vendor. They may have to hire a vendor to go back to a busy clinician or a busy hospital and ask for a medical record, have it redacted of PHI, and get that in front of a clinician, a separate clinician, to then review and say, based on the totality of evidence that you read about this encounter, did this person have pulmonary arterial hypertension, right? There are additional electronic records, things we could do where you'll hear people say, well, we validated using a claims profile, or we reviewed a profile. So we had this algorithm, but then we wanted to see if that algorithm was identifying people and was fit for purpose. And you might see people review sort of a claims profile. And there's a group within the Odyssey community that's published on a thing called Keeper that helps electronically go through a patient's profile and sort of pull out a narrative of at least the clinical encounters. But that's still using the data that generated your algorithm to review. But it can be helpful to think about, did I miss certain codes? Are there certain cohort diagnostics that people have that I was missing? There's a concept called Pharmacoepidemiology, which is I think I have it on the next slide. I might have another slide on Pharmacoepidemiology. But Pharmacoepidemiology begins to think about using machine learning algorithms to sort of take the existing data, develop a highly sensitive algorithm and a highly specific algorithm, and begin to develop some testing metrics that can be pulled out. I do have another slide on Pharmacoepidemiology coming up. So gold standard, right? Using the clinical criteria. So here's a study, validation of anaphylaxis in the FDA Sentinel program from several years ago, and you'll see the reference. We use the clinical criteria by Sampson as the gold standard. All right, so this is the really crux of, if the clinical concept is hard to define at the bedside, it is going to be hard to define in a coding algorithm. If you get a group of physicians standing around a bedside and they're all going, I have no idea what's wrong with this person, and they're billing all this stuff and they're working this very complex patient up, right? If it's hard, this is where the art of medicine meets the science of medicine, right? If it is hard to define a clinical condition at the bedside, it's also going to be hard for our data sources to define and capture this. So what is this Sampson criteria? National Institute of Allergy and Infectious Disease said, this is the universally accepted definition of anaphylaxis, right? Okay, what is that? This is a paper worth reading if you're thinking about anaphylaxis. You have to spend a lot of time with, at the table needs to be clinical experts, data experts, health policy experts that understand the provision of care within that geographic region. All 3 or 4 of those sources needs to be at the table thinking about how to develop these algorithms. So you pre-specify an algorithm, you apply the algorithm to the population within your data source, you obtain a validation sample from a gold standard. So for medical records, you either extract the clinical data or you invite a panel of clinicians to view the full records. Think cha-ching, right? Physician time is expensive time. You're pulling them away from making money doing colonoscopies to now read about their friends doing colonoscopies, right? Like that's going to be expensive. And then you assess the performance characteristics. So you certainly aren't going to do that for negative predictive value. I'm going to pay a physician to review 10,000 charts randomly selected of people who do not have colorectal cancer and have them tell me they do not have colorectal cancer. But that would be the only way to really get at sensitivity, right? Or specificity, yes. Okay, so abstraction and adjudication. You either have a trained abstractor, a medical professional who abstracts information. This can be more cost effective while allowing more extraction of relevant clinical details out of a medical record. You can then have that abstraction adjudicated, or you can have a panel of experts just review a full redacted chart and ask them the simple questionnaire of, does this person have the condition, meet the Sampson criteria of anaphylaxis, right? Okay. Validation studies can suffer from which of the following sources of error? Select all that apply. Random error, selection bias, measurement error, confounding. So I'll jump to the only one that's sort of not right, confounding. So we're not really dealing with a exposure and outcome and that piece of a third variable that's independent of exposure and outcome. We can suffer from random error. We could pull the wrong charts. We could be, oh, I'm going to do this convenience sample that has EMR data. Well, what if the EMR data all comes from academic medical centers and they differ from non-academic medical centers? And so you validate it in this convenience sample. So there can be some random error. That's also selection bias. And certainly you can have measurement error if that gold standard isn't really a true gold standard. And that's where some of these sort of machine learning and algorithmic things can begin to break down. All right. Again, great paper, the Fox and Lash work. Okay. So what to do? Yeah.
Like 100 cases, or like 100 cases and maybe 100 non-cases.
Yep. So that's exactly what a lot of people do is with regards to the selection of charts. So if you select, I think it's 75 charts. So you can do this. You can reliably say that the lower bound of the 95% confidence interval will be greater than 80% because you can play with just CII and Stata or whatever your prop binomial distribution, right? And just play with the percentage and sort of go, well, if my PPV is 80%, 75 charts, if I reviewed 75 charts, what's 80% of 75? And you can plug that in and go, but the lower bound of that will be greater than 80 or something. You can play with those numbers and get at rough, and usually it's 100 charts is sort of that world that we live in. Yes, Rosa.
So you can, instead
Yep.
of picking your sample of no cases randomly, you pick them with, so basically you are calculating the probability value of an algorithm that is designed to be very sensitive. So you pick a sample of those, and then you plug the prevalence of that screening algorithm into formula, and you obtain the negative value.
About to get to that. Yep. Coming up. Coming up. There was another question. Yeah. So sometimes charts don't come back. And so then what do you do with that? Is that a non-case? Sometimes you get, you make these requests and then you get the request back from a chiropractor and you're like, why did I spend money on getting that chart? That's not the chart I want. So yes, that's where some of the other biases, the information biases that even our measurement of the PPV, even in its precision around a 95% confidence interval, can yet still suffer from error. So all things to think about, right? All right, so wait, what are we on? Why do we validate the results? So, right, algorithm development, quantitative bias analysis. So conventional practice, sometimes flawed, you identify a validated algorithm if available. You pray that it's close to 100%. Often only PPV is reported, but of course, often only PPV is what was measured because it was basically, I have a denominator of people who my test says I have the disease. I go and review those, and now I have this gold standard, and I only have the top row of my, everybody printed it and pasted it next to their computer 2x2 table, right? Okay. And we have this assumption that false negative errors are non-differential. So, you know, we state this in our sort of limitation section. We implement the algorithm and we run with it. And we have this assumption, and then we assume that we're living in a relative risk that's unbiased. But you can go back to that newcomer paper and see that even small differences in PPV can have large effects. We can say, all right, these are poorly performing algorithms. I got to find another algorithm in the literature. I got to develop a new algorithm. You always have a clinician, well, did they include that code, right? Well, now you're changing the algorithm that was published. So, and time, right? Pre-COVID, post-COVID, things change pre-ICD-9, post-ICD-10, right? We can then ask, you know, at the risk of sort of regression to the mean, we can overfit. So there's lots of pieces to go in here. We can do some predictive modeling, or we can do quantitative bias analysis. And we're going to spend some time on that today as well. So here's what you often see in algorithm development. So this was a paper in PDS a couple years ago, or validation of coding algorithms for identifying herpes zoster among children. I know Jeff and Alexis really well. So this was done at CHOP and Penn. And this is great. A PPV for a single ICD-10 code was 92% for definitive cases and 64% for definite cases, right? So, and then when you add in, so this is some of that predictive piece, when you add in that a prescription for an antiviral, they noted that that did not improve the PPV. Now, they obviously had a thought that that would improve PPV. However, adding a new code for a rash entered within 1 week of the herpes zoster code, boom, increased the PPV to 100%, right? So these are this algorithm development, right? Where you see, and one of the costly things is you get your charts back, you get a PPV of 34%, you go, but what if I did this algorithm? Got to go back and get 100 charts, right? So this can get very costly very, very quickly, right? Full disclosure, Carillon does validation studies. So Dan's not here to defend himself. I love Dan. But if you are interested in doing validation studies, please, Optum, Carillon, a bunch of the vendors here do them, and you can happily have conversations with them, but bring these slides with you, right, to ask these questions. So Dan and the Carillon group did a developing algorithms to identify anaphylaxis. So a lot of that work that was previously talked about, and then they implemented some machine learning. And this is the talk. This is the link. Again, the slides are available. You do not have to memorize 37138. But this is a great webinar where Dan, I believe Dan and Steve Lanes talk about this algorithmic development. So if you are really missing Dan, I really encourage you to go watch this. And now I'm really hoping that that is still available online. But that was a great webinar done just before the pandemic and still very applicable today on developing these algorithms and then applying machine learning techniques, which we'll go over here in just a minute. Another machine learning piece is this concept of fee evaluator. There's a couple of in the Odyssey community, there's actually a really great debate where Joel and Dan, Joel's here at the meeting. If anybody wants to be introduced, I can do that. He works at J&J, where Joel and Dan debated, so a very nice debate, on using these machine learning methods where you're just using the data that you have. So this is using the claims data to then have highly specific and highly sensitive algorithms that then begin to refine themselves. And so the gold standard is a tarnished gold standard. It's a gold standard of, this is a very, very specific population, right? It's the herpes zoster cases that have a rash and are treated, right? So they, I mean, I don't need charts. They have to have disease, right? So it's an assumption, but it's a probabilistic piece where you then build this very sensitive algorithm, but then you also have the screening algorithm that's very broad, and you can then begin to utilize predictive characteristics to understand how to improve your algorithms. What's nice about this is all those little tweaks that you might make, what if, you can at least do these types of things very rapidly without spending $100 every time you change the algorithm to see what the performance characteristics are. But the gold standard is tarnished because it's derived from the underlying data itself. It is not a clinician-reviewed chart. All right. Shifting gears into quantitative bias analyses and how do we combat this overconfidence in our research results. So there's a great, again, it's the Lash and Fox work and Greenland work on good practices for quantitative bias analyses. And we're going to go over sort of how do we start to think about, well, how bad does my PPV and or how differential does my PPV need to be before I'm really going to start having results change on me, right? So another equation and another activity that was generated by the database SIG. So Jillian Hall, Dan Beechler, and a few others put together this, I think it's an R-Shiny app with folks at P95, just sort of where you can go online. And in years past, we've had time to actually play with this as a group. But if you've got your computers, you can play with this live here. And you can see that if your PPV and your exposed and your PPV and your unexposed is essentially the same, this would drop to 1. Hopefully everybody realizes 1 is going to give you back your piece. But this will help you understand what types of differential misclassification you can have. So you can now begin to do a quantitative bias analysis where you can take all values of PPVs from 0 to 100 and vary this and make a nice graph and sort of see where things change. Yeah. I have been asking that question myself for a couple of days now as well. And especially if your exposure is rare and your event is rare, right? And you've got 20 cases and you go out and they only have a 60% response rate. So, you know, you get 16 of these charts back and you get a PPV of 30 or 60% with 95% confidence intervals of, I can't do binomial distributions in my head, but 5% to 85%. And you're like, okay, that's my PPV and my exposed. And my unexposed PPV, I go get a sample of 100 because I got boatloads of people. And I get this PPV of 72% with some tighter confidence intervals. Am I one? Yeah. So I'm in that boat, living that dream right now. But you can play, right? And so this is relative risk observed of 1 and some varying PPVs, sensitivities, and specificities, and you can assess the impact, right? So here's the classic non-differential is non-differential, but you can see as we start to have differential PPV, its impact, non-differential PPV, but differential sensitivity, and you can begin to see the impact. So this is, you can play with this in the app, right? So you can pick relative risks, you can plug all that stuff in, and you can make your own tables and start to do the assumptions. Yes.
And as a follow-up to this work, we have now developed statistical tests for non-differentiality of sensitivity, and there is a poster in the.
We're getting to where we're going to walk through the whole meeting. Excellent. So do you know which day that poster is? Okay. Okay. So here's an example out of Dan's group that was presented at ISPE actually a couple years ago. They've done this a couple of times now, where you get a PPV in an exposed group, and then you begin to calculate what the amount of differential outcome misclassification would be needed to attenuate the result. So this is one place that you can then begin to go, well, my PPV would have to be 30% in the exposed group to change things, right? This is from the paper, the commentary that I opened up with. It's a short read. I reread it on the plane ride from Philly, so it didn't take long. It's a nice, quick read. That's where this table comes from, the conventional approach, which is what we've been covering largely through this talk today, but then also all the steps that you can do to do some validations to sort of support. And what I'm learning is why I keep walking over there is the text on this is so small that I keep wandering over to actually read. But you can begin to calculate the PPVs in the two groups from a screening algorithm and then a primary algorithm. You confirm those by a gold standard, then you begin to get those sensitivity estimates. You can begin to do those estimates and then using bias parameters sort of understand what a corrected relative risk compared to a gold standard, the Alchemist classification. Whereas in the conventional approach, you're sort of just correcting for Alchemist classification and PPV, and you have that major assumption that the PPV is non-differential, right? Okay. That's it. I hope that I didn't. Good. I've left you 45 minutes, which is what I told you I would leave you. So we're back on track. Algorithms are often imperfect. Transportability is a problem, right? These are the life lessons to take away. Be concerned about non-differential misclassification. Think about the recency of validations. Validation studies back to the question of the instance of the database. I validated it in Optum today. Is that Optum today similar to Optum of tomorrow, right? And our goal is really to get these high quality algorithms and correct where needed, and QBA can help. So I hope I did Dan justice there in not all my material, right? All right. Great questions, and I encourage everybody to follow up with Dan if you have like really want to get into the weeds. I think he'd be happy to outreach. Start the subject with Kevin was terrible. I need to learn from you. I need to validate what Kevin said. Right. I am a tarnished gold standard.
Anyone want to stand up and give a little stretch? There's like some blood pooling down in our ankles here. Hope you're well hydrated. Okay, wrapping up in about 40 minutes or hopefully less. My name is Sudha Raman. I'm an assistant professor at Duke University. There's a population health sciences department. I am a pharmacoepidemiologist, but I had sort of a long and winding road to this place. I am in this department that has a number of different kinds of researchers. And so what I really like about this topic that's a little bit more expanded is, yes, I'll talk about linking, but I'll also talk about what is increasingly happening in research is that we're using multiple databases. So not only just one data source at a time, but multiple data sources together to find answers to our research questions. So my conflicts are non-directly related. I do get some salary support. Duke is part of the operating centers for some of these distributed research networks. And so I have some skin in the game. And I'll talk about them, but doesn't really bias what I say about them. We're talking about sort of multiple data resources. So we're thinking about the data banks and the data sources, and perhaps we've often done studies in our dissertation that kind of look at, one data source. Why would we want to look at more than one data source? So we'll look a little bit talking about stacking data on top of each other so that we have more observations. And then in the linking section, I'll talk about putting two data sources together so that we're actually talking about more information about a single observation. So essentially, I think we've gone through that. We have these data sources that are in the real world and routinely collected because of some other process other than research. And each of those data sources has its limitations, as we have discovered, both in scope or coverage or in power in terms of the number of people. And so the methods or the kind of approaches that I'll be talking about today will kind of try to piece together some of the ways that we can mitigate those limitations. So the other reason is that really we need to think about our research processes and how to make them more efficient, how to make them more timely, as given by the example of the pandemic. And we need that evidence as sooner rather than later. And so it really is upon us to look at different ways that we can use multiple databases across countries, perhaps, to get fundamental sort of knowledge about a disease process, or as well thinking about how the culture or the healthcare system in each country might impact the ways in which our treatments may or may not work. And some of the large regulatory bodies across the world have kind of called upon us to be thinking about bigger data. Bigger doesn't always mean better, but in this case, we'll talk a little bit about how we can use and how we can structure our work. If we don't, think about these new ways, some of these implications can be quite significant. One of the interesting reads that I had as I was developing these slides is that, thinking back to 2004 when Vioxx was taken off the market, it took 5 years for that to happen. And people have sort of simulated that if we had more data, more patient data from 100 million patients, for example, we could find those same sort of signals in just 3 months. And so that speaks to the amount of sort of patient impact that we could have by doing multi-database studies well. So why would we do this? Conduct these multiple data source studies, or MDSs. We obviously want to increase our sample size, and that allows us to potentially get signals faster or do the analysis on subgroups of interest. If we link data sources about the same sort of entity, then we can also increase the breadth or depth of information. We can get more detailed information from one data set about treatment or labs or some clinical information that really complements the limitations of the other data set. We can use it for validation, as we've just sort of talked about, either sort of formal validation, but also for the consistency of results across time. If we actually want to know whether a medication works, it does help us to do that analysis in multiple data sets, to get that Bradford Hill criteria of sort of consistency across different studies, except doing it all at once, and to increase generalizability, to kind of look beyond the one database and the types of patients that might be represented in other databases. So traditional epidemiology has a way of doing these multi sort of database studies in a traditional meta-analyses, except the difference in there is that the meta-analysis looks at all the results of studies after the fact. So the main disadvantage that you'll see in every meta-analysis is that if they were able to do one, they often have much comment about the variability in the methods used to define their outcome or define their exposure. So a multi-database study generally is done all at once, and it has this common study protocol that allows the researchers to kind of specify study design features, like a common exposure definition, a common outcome definition, and then so at least can try to mitigate or decrease some of the preventable heterogeneity that can come from doing a study in multiple databases. So what this great article by our esteemed colleague, Rosa, helped me to understand sort of the different ways in which multi-database studies can be done. And this was using sort of the European experience, but I think it really is kind of common to think about the different ways in which we can do this. So there's the straightforward, like old school way, is where you call up your colleague and you say, okay, I want to do this research in your database and our database, and can you just send that over to me? So that doesn't really work anymore. I'm not sure that it ever really did. But if that did work, you could pull the analyses at a central partner and conduct the analysis. And that is increasingly not really feasible in this land. So I'll be talking about the second version, which is where you have a study with a common protocol. You don't need a common data model, a CDM, a way to kind of standardize the definitions across a priori. But you can then share sort of patient level data or aggregate data to kind of pool the data and get an estimate. The other way that's increasingly common, and I'll spend a little bit more time talking about, is when you have a general common data model, and you put the data into that model, and then you apply a distributed, or let me just say it the easy way. You just apply an analysis plan to those data at the local level and have the results come back to centrally. So I'll be going to some of these. I got confused. Should I talk about common data models first or distributed research networks first? And essentially I realized you have to talk about them together. So that's the talking about them together, and then I'll kind of delve into one at a time. So the shared patient level, this is what we don't, it's really difficult to do given the needs for ensuring patient record privacy and security. The common protocol is something that can be done. It's actually a study that I participated in, looking at something relatively simple. So it wasn't looking at sort of a safety or effectiveness question, but it was really looking at the trends in medication use for ADHD over time. And in this study, there was a common protocol that we asked partners in 15 different countries and 17 different data sources to enact this protocol to estimate sort of age-related trends over time in ADHD medication use across these different jurisdictions. So in this case, the common protocol was sent out to each of the partners. This visualization just shows 3 different partners. Those partners applied the common protocol in their own way, understanding that they knew their data best, so they knew how best to define the different medication groups or the different age groups. And the sites then shared the aggregate data that we were able to put together into our final result, the paper that came out before the pandemic. So, this is the result of a lot of different work and a lot of different thought to think about, to specify to each data partner, what do we mean when we talk about children? Are we talking about people up to 18 or 21 or 25? And what kind of measurement do you have of age in children? What kind of medications do you use in your country, and how do we define ADHD medication? How granular can we be with breaking that down? So all of those sort of questions were things that we try to specify in the protocol, but it's relatively time consuming and requires a great care in figuring out the quality of the data that's coming from each of the sites. And though we were able to sort of describe some of the differences in the healthcare system, we weren't necessarily very, very detailed in our paper about what each country used to define each of their variables that they sent to us. So I thought that this, it was a good example, and I will say that this sort of collaboration has evolved into sort of more of a network where they do a little bit more than a common protocol. But I think the common protocol really enabled us to leverage multiple databases to kind of get this done all at once. So infrastructure and tools. So this is a little bit meta, right? We're talking about not only what you need to do research, but what needs to exist to do sort of this bigger type of research. So there are established distributed research networks, and I've listed a number of them that exist here in North America and in the EU and elsewhere. And there are a number of disease-specific ones and growing networks that are sort of developing as people decide on research questions that need a little bit more tailoring. But essentially what the 2 things I'll talk about are distributed research networks and common data models. And I'll have to explain what a distributed research network is to talk about common data models, and then vice versa. So in a distributed research network, what happens is that you have these, let's say, 3 different data sources, and each source has its own way, depending on the provenance of the data and where it comes from, of structuring the data and the form in terms of and formatting the data. And what a common data model or a CDM allows us to do is to transform each of the data from each of the sources into a common model. So there's a similar structure and format, a varying sort of granularity. So this allows us to have, instead of 3 divergent different data sources, we take those same data. We're not adding data, but we're adding a layer of interpretation to make these concepts a little bit more comparable. And what that allows is an analysis method that is more a common analysis method to be applied to these data that look more similar, and then allows us to get these analysis results. So that's the short version. You can sum it up in that what this allows is the common data model allows us to get a central analytic package that we apply at our site locally, and then we can share those results, whether they're sort of patient level results or aggregate results, and pooling them in a different way. That's the whole idea of a distributed research network, sort of an infrastructure that's set up to do these bigger types of studies. So let's talk a little bit more about any questions so far. I'll get into common data models and then into distributed research networks. Yes. Right. So that is a good question, because essentially it depends on how closely those variables sort of are. So I'm trying to think of an example. You can't make data. And I don't know, you can't make data. You can maybe talk to the people who know the data really well and say, where would I get this concept? Like a prenatal visit. Is it, can I get it from the codes? What happens in a common data model is that each data source has to, people sort of get together and decide on what are the elements of a common data model. And then they'll decide, each data site will have to decide what elements of their data represent that concept well. We can't represent a concept that doesn't exist in your data, but you can see if there's sort of adjacent data characteristics that maybe not named the same or maybe not capture the same. And you have to make those decisions on a sort of site-by-site basis of whether or not that particular variable fits into what the common data model variable is that's requested of you.
Can I elaborate?
Yeah.
What is normally done is actually that when you do the common data model, you simply transform your local data like verbatim.
As best as you can. Yes.
And then what you're saying is creating a new data set based on the common data model using the same program that may, however, do different things in the different sites. That's the ultimate transparency. So,
yes,
our data are different, but we transform them in a kind of agnostic way into the same columns and tables. And then we use the same program to create diabetes, but the same program does something different in your instance of the common data model than in mine. And in this way, it is completely transparent and reproducible because the program is the same and shared.
Right. So you can't. So I suppose there are a lot. Let me get into let me go through a little bit on how it kind of develops, and then we can kind of get back into where it can go wrong. So imagine that we have 3 different data sets, and each member of the team says, okay, we want to we deal with the same patient population, and we would like to put these data together, and we think we all use the same electronic health system, so we think that it's going to be relatively easy to put these data together and find and analyze it. But we understand that there's going to be this heterogeneity, and that we have to try to make these data more similar, and that will take a lot of money and time. And so when these 3 data sets come from these 3 different sites, they're going to be different, and we're going to run into problems. They know that because data at each institution are represented differently, even though they might be about the same concept. So here is an example where 3 different sites have what they put in as like encounters. And so there's all different types of encounters. Some of them are classified by location. Some of them are classified by patient, clinician, or the reason for the visit. But in the common data model, we're trying to get to sort of like a more consistent clinical concept. So in the common data model, like a particular common data model looks at encounter type and says, we want to think about an ambulatory visit, so an outpatient visit, an emergency room visit, and an inpatient hospital visit, and some others. And so what each of the site has to do is say, okay, we have all this kind of information in our encounter data. we have to figure out how to map that into the common data model. And they'll be making individual site-specific decision-making, which should be transparent, to get themselves into the common data model. You can imagine this takes a lot of site-specific understanding of the data, and then there's a lot of decision-making that to get yourself there. So even though the data may look the same and be structured the same, it can mean slightly different things at each. But what we're hoping is that in the common data model that we're able to distinguish accurately the difference between an ambulatory visit or an outpatient visit and an ED visit. All right.
But so while things don't get necessarily imputed, things could get translated. So one informatician sitting in at one academic site and go, I didn't know how I could make an ED to IC
Mapping.
thing. I just made them all ED. And then when you run the data quality, you're like, that site has a heck of a lot more ED visits than this comparable site across town. And it's all because that person can figure out how to make an EI thing out of intake ED to IC. So while it may not be included, it translates. Things get lost in the translation.
Yes. Yeah, I would say that's like an advanced idea, but yes. Right. And but the problem is that the impact of the site on the association can work in multiple ways and very specific contexts. So like you can stratify it, but there might be multiple kind of mechanisms of error coming from like the data. I mean, we're just sometimes working on like, can I get all confounders that I need? So that looking at like this understanding of like where the data comes from is really kind of like the next level. Like we should really work on that. So I suppose like what we know is that like this is what we're starting with, that each health system or entity or country's data is optimized for something else, for what they want to do with their organization, and the common data model allows us to compare those a little bit more consistently. It's close enough. It's not necessarily exactly what we need, but for some of the work that we do, the common data model allows us to, in very specific areas like encounters and medications, it allows us to change that raw data into a structure that can be standardized across multiple data sources. And then it's more shareable. And some of these slides are from Pharmacoepidemiology, a US-based EHR network, to give credit. So some of the common data model categories are like areas that people that are really useful in pharmacoepi, obviously, are the diagnoses and the procedures and conditions. And you can see that kind of the structure is very similar to some like EHR and claims data. And what that allows us to do is, so here's an example, for example. Each box, so this is a Pharmacoepidemiology common data model. Each box represents a table in the database, and each item within the box represents a column in the table. So the procedures column is down at the procedures table is down at the left, and in there there's an ID variable for the patient and the procedure, and a code for the code representing the procedure and the patient. And so most common data models start with sort of a core set of tables and then slowly add over time. And there are multiple common data models. So there's think about it as like flavors of ice cream. They all are yummy and sugary and sweet, but they all have different sort of flavors and focuses. This is the common data model for the Odyssey network. You can see there's still like the core tables in terms of device or medication exposure, but they do have different sort of information about the health system, which is maybe speaks a little bit to what you were talking about, and cost variables and different types of clinical concepts or non-clinical concepts are reflected in the different common data models. Yes.
OMOP to get requires so much of what we would call mapping, meaning that you have to take ICD-9 and then ICD-10 and read code, and they map to SNOMED or other stuff, the concept codes within you put in here. But if you go back to the CORNET model, if you strain your eyes, this thing looks like what is sitting at the back of an EMR at the hospital in the University of Pennsylvania's Epic. Although there are tens of thousands of tables from Epic or Cerner, this is information that's extracted, but it largely sits untranslated because there's still the stored code of ICD-9 and 10. But then to use this then requires a lot more thought in thinking about what codes and code systems. This doesn't then transport as well across countries because you have to have a code list of ICD-9, you have to have a code list of ICD-10, you have to have a code list of reads to be able to play across networks. Whereas within Odyssey, if a phenotype was developed, then as long as everybody trusted how that ETL happened, then there's that transparency.
A question on that though. So if you think that the ICD-10 codes of one data source can be faithfully transformed into SNOMED live ETL or the ICD-9, why wouldn't you do that on the fly while analyzing it? You can build the same map. So exactly. So why is that? Why is it so important to do it? Yeah.
No, it's done during ETL because then it's available and ready to be used instantly.
Because if you know that ICD-9 code is equivalent to that SNOMED code, you can make transformation.
I think that what the common data models and the distributed research networks, from what my understanding is that it's helping us to be more efficient so that we're not having to redo things that have been done before. And so some of these, I mean, I would say like the CORNET, we should have clarified is US based. And this is why it looks like US centric. And sort of more claims oriented, and Odyssey is an international sort of body. And then what they're trying to do is make it so that multiple countries can work together, and data sources from a more heterogeneous group of data sources can use this common data model. Would you say that's correct? Right. And so I think that also we started to use an acronym that we hadn't defined. So ETL means extract, transform, and load, which is the process of getting it from raw data to the common data model. So in the source data, for example, we have ID, birth date, race, ethnicity, gender, for example, and that mapping to like the very detailed Odyssey, OMAP common data model, which is on the right in purple, they have different variables for each the year and month and date of birth, the race concept ID, that they have different, and they also have the source values as well. So I think that this whole mapping process allows a type of transparency of taking the data source and making it into a little bit closer to the analytic variables with more homogeneity. That's what we're aiming for, right? Do we get there? And what do we have to consider on the way? So one of the things that, sort of looking at the different common data models, you might, as a health care institution, you may be thinking, well, which common data model do I use? As a researcher, you'd be like, what does it mean when I have to use this common data model versus this common data model, or the data source that is sitting there? Do I want to use the raw data instead? We have to be thinking about what do the variables and the tables mean for my research? What data elements are more easily sort of formatted across different data sources? You also have to think about this element of time, that these common data models are not static, they change, and also the data sources change. So those detailed specifications must also be changed, and not every time that when a data source changes, do you notice the implications that it could have down the road. So for example, the detailed and transparency in terms of the specifications of making a common data model can vary across the different common data models. This is an example. There's sort of 200 pages, and I would say that 200 pages is not enough to tell you how to map a whole entire EHR to the CORNET common data model. Of course, I shouldn't say that to the people who have to do it. I'm sure they're having, so this is just like a tiny little abstract of like 4 variables that are really, really clearly, relatively clearly defined, but you kind of see that not only do you have to think about sort of what the values are, what they mean, and then that what I found was interesting was that last column on the right is the field level implementation guidance. Now, I bet that that was relatively empty when they first started. And the way they found those guidances is by what Kevin said, sort of as you got the data from the different sources into the coordinating center, they were taking a look at all these variables and wondering, like, why are things different? They go back, there's a phone call that goes back to the people who know the data and try to find the right person to tell us why these differences exist and whether that has to do with the data or that has to do with the way the data was transformed.
So your question about data, so I asked the question, and I see rates. Is it patient self-report or is it computed based on some algorithm? I used to live in the same zip code and met the African American 17. And like we had coffee, and we couldn't have been more different. Our voter registration got crossed, a whole bunch of things got crossed. And so I asked the question: did race, is it self-identified? Is it patient reported? Because way upstream it could have been imputed, right, by another human even, right? And so that data provenance, really understanding somebody's data. To your question about real-time, I would love a smart on fire application that took my University of Pennsylvania Epic EHR and I could push a button and have it ETL live to CSV files for my own purpose, to load on my own local home network attached storage in the CoreNet CDM or in the OMOP CDM. That doesn't exist. So I think there's still a lot of need for the informaticians in the back end to do these ETL processes.
I was just thinking of the transformation between
Right.
Why would you do this? What is the difference between the data after? So if you're saying that for one,
If it's done up front, then it can be used for repurpose.
But you also use it up front. If you know that data is always means that's over. Doesn't change. You do it follow up.
For coding systems, that makes sense, but a lot of these data sources aren't as straightforward, right?
Security, for example, we have reports from the GPs and IT9 code and paper from ATS and IT9 code from oil. So when we link them, doesn't matter.
Right.
We're gonna find them anywhere. So
Yeah, I mean, this is exciting, and it's really neat to hear your all experience as well. I'm gonna just conscious of the time. Like, is it really 1:15? So I suppose that the point of this slide is to say that that a common data model is part of an infrastructure that really takes a lot of work. The sites have to sort of not only transform it once, but then refresh for new patients, new events every quarter or every half year, depending on the distributed research network. And a single site might actually have their data in 2 different common data models or more. There's also this concept of data curation. So it's something that explores data quality and conformance, looking across different sites, and it allows the sort of a coordinating center or like the research network in general to think about how data quality might differ across institutions or data sites. And they have sort of this reliability checks, which helps you a little bit. Doesn't tell you how relevant the data is, but it does tell you the data are, but it really does tell you whether or not we have things that we could fix, perhaps, like looking at values that are in the future or looking at outliers in the data. So that curation process is increasingly being automated so that the distributed research networks can do some of the work that we used to do hand by hand combat with individual databases before. And as I sort of alluded to earlier, what the common data model does is allow you within a distributed research network to support these distributed queries, which are written, sort of program codes that are packages that are written by one site in pursuit of a research question or a feasibility query and sent to the other site so that they're able to run those same queries on their data with little to no modification, so that we're easily able to say, instead of 2 weeks for someone to say, or 2 months for someone to find all the diabetes patients who meet a certain criteria because we want to run a clinical trial at your site, we're able to kind of send that query to their data, get the response back relatively quickly with reduced costs and resources on the site on the part of the site itself. So I think I've kind of hit all the common data model summaries, and maybe even some like sidebars that are really, really important to think about. What that ends up happening is that, the researchers are happier because we have some of the work done for us, and we're able to kind of work towards sort of a bigger and more impactful, potentially, research. I mean, it's a hopeful. We're always idealistic, right? I sometimes am called, or maybe I self-identify as a wet blanket of real world data, and I would like to also temper that with a little bit of optimism about what we're trying to achieve in the future. So a distributed research network, I think we've got the idea now that we have individual sites or data partners that hold their own data. They allow access to this data indirectly by having these programs that come from a central location to apply to their data. They can send results back so that these results can be sort of pooled and however, it really does present a lot of administrative governance and sort of analytic challenges. The benefits are, I think we've figured out now that we could maybe have access to more data, assuming that more data is better. We may have, which is definitely the case in rare outcomes where usage or uptake is slower, where we want to get a different population. You can also think about this not only in the context of observational studies, but think about, there's a whole paper that I was involved in that talked about how these distributed research networks can help us prepare and conduct randomized clinical trials, so that we really are thinking of different ways of doing research. And then it also allows people to have control over their data, which is really important because ultimately the data does belong to the people who generate it, I think, as opposed to the people who hold it. And so these distributed research networks have those advantages. And we've talked a little bit about, and I would refer you to actually explore the websites of some of these main distributed research networks. They each have their own purpose. So the FDA is important, looking at safety and effectiveness. They have, large numbers of people, but they also serve a certain purpose in terms of looking at the medical products that are licensed here in the US. I keep saying here, but I know I'm Canadian. Here is not, I mean, North America, right? UDIN is a network, a distributed research network in the EU, and I'll refer you to the site to kind of, each of these has their own sort of specialties and their suite of services. Like in addition to having a common data model, they may have different ways to kind of query data and get feasibility estimates, and different ways to engage researchers in conducting sort of studies that can look at larger sets of data. Now, sort of go a little bit on to this slide, which I think I've sort of, if I haven't impressed upon you sort of the complexity as compared to doing a single database study that's involved in a multi-database study, the slide kind of covers it all. When you have researchers working together, you really do need sort of an overarching structure of oversight to kind of determine what the mission is of the research network, and then the day-to-day operations in terms of the study oversight, the network maintenance, core committees that decide what's going to be in the common data model. How are we going to make these changes? How are we going to deal with actually getting these data common sort of the data use agreements in play and kind of updated and securely sort of transferring these data sources or data between partners. And that's not even to talk about sort of the analytic concerns. Obviously, the limitations of the individual databases still exist, and adding a common data model on top of it does not sort of erase all of those. And so you have to have your epi hat on and be thinking about sort of the different levels of bias that can come from putting your data in, and what you lose in terms of granularity and specificity when you're looking at when you're putting things into a common data model. It sort of seems like so sad that data linkage, which used to be like all of it, is now sort of relegated to the last 5 minutes. But I think in summary, I'll just say I talked a lot about the data stacking, because I really feel like there's, as you look around at the database, like the abstracts that I reviewed and that are presented here, we'll see that like using established data sets and what we've learned in the first 3 presentations is one thing. And then there's a whole level of sort of evaluation that you have to, and questions you need to ask to figure out what it means to have for data or studies to be using common data models or distributed research networks for their studies. The linking aspect, I can't do this justice, but I will refer you to resources that can really help you, and you're welcome to ask questions. But I think the one thing to see is that it's a different way of putting data sets together. What we are doing is looking across sort of like, let me define it. So we're looking across 2 or more data sets, and we're adding data together that are talking about the same entity, whether that be a family or an individual, so that we're able to kind of understand more about that observation. And there's a number of reasons why you'd want to do that. You want the breadth of data. Perhaps there's data that doesn't exist in one, like Kevin's example of like, I need to extend my follow-up time into adulthood. Or you can be thinking about, I need to control for confounding better, or I need to be able to understand or validate something. So there's lots of examples of data linkages that are already done. Some of the existing ones are sort of in the European countries, where they have these national registers, and the link is already done for you. The paper that we talked about, there's two papers that came out of a group here at ISPE that were really thinking about what happens if we want to link data ourselves. Like I really need a question answered, and I can't do it with one database. I have claims database, but I really need the ability to look at these clinical details to adjust for confounding, for example. So these 2 papers kind of outline 2 different aspects. We don't go through like the technical aspects of how to link, but we looked at all the things that you need to do to assess the databases and their ability to link. And then we looked, once you've done the linkage and we've done perhaps the research, we looked at what do you need to report about the process to make that so that readers and consumers of research can understand what the linking process was and how you evaluated your linked data. People love to link the data and then run and do your substantive research question. And then people aren't so interested in doing the sort of like the basic methodological and descriptive work about the linkage itself. And it's super important because that process itself can introduce a measure of a degree of bias from the linking process itself. I don't know how to sum this up too quickly, because it is my total conclusion slide. Oh, I know. Well, we wrote the paper. Okay, we wrote the paper. So, I mean, there is the paper to kind of take a look at it. But I would love to have the questions about the distributed research networks and the common data models, because I feel like these are things that we definitely need to learn. Let me go down to conclusion. So we talked about sort of multiple data sources. We talked about common data models and how they help people to build these distributed research networks that allow us. And I think it's really important to understand sort of the mechanics, the operationalization of these distributed research networks, because they allow us a way to use these databases in sort of a more concerted and one day, hopefully, efficient way, right? And linking databases is just another way of doing that. And I hope that you're able to get at least a little bit of background to kind of consume the research that we see here at the conference as a better.
Yeah, no, I want to do that. But I also want to ask you, so I know we're running low on time for questions, but I want to think about potentially doing the linkage talk as something that we record as a webinar through the year as a database SIG. So we could think about that. Because given there's an enormity amount of content here. But I did want to spend just 1 minute going through the program quickly to remind folks that there is a database SIG meeting at 7 during the SIG meetings on Friday. That is a great place to continue this discussion. The other thing is there's a database poster walk on Sunday, which will actually walk through some of the highlighted database SIGs. And I purport that databases is every single presentation, right? So part of this, there was 2 goals today. One, arming you to help you make better decisions in selecting databases for your own research, for your own research questions. But second, to be thinking about how we evaluate the literature that we read, the posters that we see, the podiums that we see. So now you're all armed with being able to walk up to the microphone during a 15-minute, when the panelists go, are there any questions? You should always have a question. Yeah, Kevin Haynes Jansen. Did you validate your outcome, or how did you, or in the linkage? Yeah, so I saw that you linked. How did you do that linkage piece, common data model? Yeah, what were the challenges in distributing that research query across multiple? Right, so you are all armed. You are all armed. So I expect now to go out there during this meeting and hear lots and lots of questions. And you could start it with, I took this database course and I have this question. So with that, I will close. Are there any sort of final thoughts? Did we hit the mark on the objectives? They will be, yeah. So good point. I think because they were loaded yesterday and today. No, so the PPT, the PowerPoints are supposed to magically be made into PDFs on
the PowerPoint before like 2 o'clock.
Yes, so that's why they will be there. The system, that's why they were due on Friday, or what was it? Was it Friday? Saturday, Sunday night. All PowerPoints were converted into PDFs. That's without, but okay, all right, okay. We will work on getting the PDFs into the system. Yeah.
Yes. We can do that. Yes.
Yeah.
Great question.
This was not.
It's not.
Be in the present, the moment.
Right.
They
Yeah.
have. I don't know if do we still have access to like 2 years ago,
Yeah.
those short versions? So there's still, if you had access to those.
So what we could do simply, we could do webinars for all the
Correct.
cohort presentations over the year.
Then you can actually have Dan.
Even though it's price, but I think.
Yeah, so we can do a lot of co-learning with the database SIG and the education committee throughout the year to extend the learnings. Certainly provide that in any of the feedback, because I think the education committee will see that and then go, how do we expand this? I know I was supposed to, and I haven't done it yet, I'm supposed to record a 10-minute version of this entire day. Yeah, or maybe 15. And I was supposed to do that. I have a Zoom link to record well, it was like a potpourri, because they're trying to use these as like, because people's attention span is YouTube videos. So you guys are gonna make it go viral though, I'm sure. But yeah,
Yeah, I know that they, sometimes, I think it's within the app, you can actually provide feedback, right? I think in the
Yes.
app itself. And so I would, any feedback is helpful. even like what the stage of your research or like what you were particularly interested in or what you liked and what you don't like, anything, I would advise you to kind of in your next course or over the break, just add some of that feedback in because we do look at it each year and change the content depending on that.
And also thanks to all of you because I think it was a very nice audience.
Yeah.
A lot of questions.
You guys asked a lot of questions,
Yeah,
which was
yeah.
great.
Love that. Thank you very much.